to how you work with your own clients. Okay, now kind of notice the next part because I'm going to ask you some questions about this in a minute. Professional demands, challenging workplace climates, and exposure to trauma warrant that social workers maintain personal and professional health, safety, and integrity. Social work organizations, if you're a boss, take note. Social work organizations, agencies, and educational institutions are encouraged to promote those kinds of policies and practices. So how this trickles down is NASW will then send all this over to the Council of Social Work Education. So I work in higher ed, and in higher ed, there's been a real push to incorporate more self-care. So we now have it across the curriculum. We include self-care in all 4 practicum courses, in our Practice 1 and Practice 2 courses. So you get it basically in 2 classes every semester. This is how important it is, and this is how it's coming down for you folks, because you're going to start supervising students who have had this training, and they're going to be coming in going, "When's spa day?" Yeah. Spa day? Really? Yeah, what are you talking about? Really? Spa day? We had that in the clinic I worked with in Texarkana. We did. And we had a boss that was really on top of this and really into self-care, so she brought in a specialist, and we did yoga nidra during lunch one day. Oh, everybody should have an hour of yoga nidra. That just is so nice. Okay, so think about this. So not only is social workers asking that, how are you doing? How are you doing in your workplace? How is your boss supporting self-care? But also, how are we bringing up the rising social work generation with self-care? Okay, so, and those of you that are remote, I hope that you have 2 devices. So the one that you're looking on, live.voxvote.com. Yeah, it's the self-care quiz. You'll see that. And that's the pin to get into it. I know I have a. Chrome. Okay. So, do you see where you're at? We're going to do one question at a time because the results are going to come up on the screen. Isn't this kind of cool?
Sorry, I'll show it to you just a second.
Hold on, she's going to show you. Yeah. It's all right, we all need some self-care, right? If we're getting anxious over a quiz that doesn't mean anything, doesn't count. Okay, so here's the first question. You all there now? Oh, okay, hold on. I'll tell you what, why you need some self-care. I'm sending around some Zen Garden lotion, okay? Feel free to use some. I can't use this in Texas because it sits there. You rub it on your hands and it sits there. It doesn't ever absorb. So please, feel free. We all there? Think so? No? Okay. Can wait another minute. And hopefully those of you that are remote, that you're there too. live.voxvote.com with a pin of 166248. Okay, we ready? Here's question number 1. Let's answer that one. How has the climate of your work environment changed since COVID? Meaning, what's the atmosphere in the workplace like? You have really good vision. Oh, look at what we got here. Yeah, keep voting. Okay, this makes me happy to see this, actually. So more than 72% of you have had work environment that either has stayed the same or it's gotten better. Good, somebody's listening, somebody's hearing. But look here, we still have more than a quarter of you that are struggling with environments that have changed not for the better. And that toxic one. Okay, so 123 of you have voted. That's pretty good. Oh, 125. Okay, we'll stop now, so if you haven't voted. But that's nice. I'm glad to know that 70% of you are at least in a place where it's not so bad. Okay, so now since COVID started, since I saw you last 2 years ago, how has your workload changed? Hit reconnect. Well, I wanted to do this quiz because you got it? Okay, yay. I just didn't want you to have to say, I work in a toxic environment when you're sitting next to your boss. Not doing that. Okay, oh wow, look at this. Those of you that have a decreased workload, can we meet right after in the atrium there? We'll have a nice little chat. I'd like to know how you pulled that off. Okay, so the majority of you, your workload has increased. Maybe a little bit, maybe a whole lot, okay? But that's significant, isn't it? That you now have more work. I'm just curious to know, I didn't put this in the quiz, but I'm wondering, of those of you that have now increased workloads, how many of you are getting paid more? Okay, 0. Okay, let's do the next one. Okay, I'm really interested in this one, and I promise I will not be using this for any research or anything. This is just for us to talk about here. Your third question, how much change in the trauma you are seeing in your clients? So what they're coming in presenting with this, how much has that escalated in the last 2 years? Oh, gee. Is anybody surprised to see this? Not at all, huh? Okay. I noticed that nobody's seeing less trauma. That's very sad. But that significantly more is a huge number, isn't it? It's a big percentage. So you're working harder, your workload has increased, the intensity of the work that you're doing is more, and the environment for many of you is not any better. For some of you, it's still kind of the same. Maybe it's a little better. Yay for you that are in better environments. Okay, so you kind of see where you are here? Go ahead. Okay, so now here's question number 4. How much, this is why I really made this anonymous, okay? How much does your employer provide opportunities or support for your self-care? Notice how I've kind of put this. Some of them just don't say anything. It's your thing. Some lip service. Oh yeah, I care about your self-care. You make sure you just do that. Acknowledge the importance. Yes, self-care is really important. You've got to take your vacation days. Okay. Wow. Now, the 2.7, not applicable, I'm assuming because you're in private practice. You're your own boss, okay? And if you had pretty bad scores, that would send you a loud message, wouldn't it? Okay, so look at this. We've got almost half, actually more than half, that aren't getting support from their employer to take care of themselves, in spite of the fact that your workload is tougher and it's grown a lot more. You're not getting that kind of self-care support. Those of you in here that are managers, I hope you're taking this as a clarion call, not as an insult or a dig or anything, but oh wow, this is something we need to do. We need to pay attention to this. Okay, let's do the next one. Okay, have you considered changing jobs? Not at all. Yeah, I've thought a little about it. I've seriously considered it. And actively planning to change means you're working your network, you're tightening up your resume, you're getting ready to get on the market, or maybe you've already thrown a few applications out there. Wow. So only 22% of you haven't even thought about it. You're happy where you are. Yay for you, 22%. Yay. Okay. And the casually thought about it. Okay. But look at that. More than half have either seriously considered it, are working on it, or have already made that change. Folks, this is huge. But you know what? If the other questions that I've already asked you are consistent with that, then of course you would be looking for something else. There's nothing worse than feeling trapped and stuck in your own employment. So some of you have already made that change. Look at that, 1 in 5 have changed jobs in the last 2 years since I saw you last. Wow. Okay, last question. Here we go. How often do you engage in self-care each week? No lying. And I probably should ask how you define self-care, because coming home at night and watching TV for the whole evening, no, doesn't count. No. It's better than working 12 hours a day, right? Okay. Okay, I want you to take a minute and chat with your folks at your table. What are you doing for self-care? Change it back to yeah, if you don't want it, yeah.
Yeah.
Okay, I just want to know what kind of self-care you're doing.
We're just mocking our boss. So we're doing great.
Boss, not so much.
We may be unemployed at the end of the day.
That's why this was anonymous. I'm not trying to contribute to the employment change. Okay, so those of you that are doing self-care 1 to 2 days a week, okay. Now I need to ask you a really serious question. I know you guys could you put the social in social work, I get it. So let me ask, so half of you are doing 1 to 2 days a week of self-care. Is that enough? Okay, yeah, it's not. You know it's not. That means 5 days a week, you're not doing anything to help yourself. That's problematic. Where is the lotion? Is it going around? Okay, good. I want to make sure everybody's smelling something nice. So yay for the 37% of you that are actually doing stuff. Yay. The 14% of you, we're going to meet in the lobby during lunch, okay? We're going to have a self-care workshop. Just kidding, just kidding. Okay. So tell me what this looks like for you. The stats are nice, but self-care isn't an option, and too often we treat it like it is, right? And don't ever use this excuse, well, I don't have time. I don't have time for self-care. You don't have time not to have self-care for your own sanity. You're working harder, your clients are more distressed, and your environment isn't as healthy as it was before the pandemic. By majorities, some of you, there's obviously differences. Okay. So here's the other addition to the NASW Code of Ethics for this cycle. Social workers should take measures to care for themselves professionally and personally. So this is something I want you to take home and think about. What are you doing? What are you doing for your own self-care? Legitimately self-care. And then what is your organization doing to promote it? This is now a social work ethical issue. So those of you that are bosses, including the guy over here who's all of his staff is going to leave at the end of the day, or he's going to fire them, right? How's that working? We have to take care of our folks. If we don't take care of our people, we're going to see more people changing jobs because they'll think there's something better somewhere else. What? Wrong way. Here we go. Okay. So I want to make sure that you think about this and you apply this to your life. If all you're doing is coming in here to, check mark the box that, yeah, I got my 3 CEUs of ethics. I get it. I have to do that with the human trafficking in Texas. We have to get our CEUs for human trafficking. And it's not that I don't care about that issue, but I'm in the middle of other stuff too, just like you are. I'm willing to bet 2/3 of you have already checked email since we started. Maybe answered a few texts. I get it. But what will you take away from this that you can apply to your life that will help you? Because it doesn't matter what the statistics or the percentages say. What matters is how you answer those questions and how you can make it better in your own life. Okay, here we go. Cultural competence, ACA. So they mention it, using the profession and practice to promote respect for human dignity and diversity. And then that's in their mission statement. In the preamble, it's honoring diversity. It's very nice. There's nothing more mentioned in there. I lied. A4B, counselors respect the diversity of clients, trainees, and research participants, and then they get training to work with populations they're not real familiar with. And then don't discriminate. That's all. That's all there is. Maybe the American Counseling Association trusts counselors more than the National Association of Social Workers trusts their social workers. APA, there are no psychologists in here. Skip. Okay, how about that? Okay. Marriage and family therapists, the half dozen of you that are in here. Not ethical standards, but what MFTs strive for. See, it's not a standard, it's just an aspiration. Doesn't that sound nice? So if you're an MFT, acceptance, appreciation, and inclusion of a diverse membership. In other words, we welcome everybody to be a marriage and family therapist. And we want to do really well working with diverse populations. Yeah, that's it. Okay, now we have the social workers. Okay, folks, start to feel those lashes on your back. But I want you to look at this because this isn't just mental. This is you have to demonstrate. Look at this. Social workers should demonstrate understanding of culture. This is new, added this year, was demonstrate. So it isn't enough to sit through a diversity CEU training. You have to then turn around and show that you can act on what you know. You also, and I love this about social workers, I think this is a lot of the reason why I became one, because you recognize the strengths in cultures. You understand that those are assets they bring to the table in your work. Boy, that can be a great strength. And then again, social workers should demonstrate knowledge that guides practice with clients. So if you don't know a lot about culture, in all my years of teaching, the standard has been, we teach them to be humble enough to ask. Ask your client, well, okay, so help me understand your culture. I want to understand how that's a strength for you and how we can, I want to be able to be sensitive to what you need, okay? It's not enough because not only do we have to demonstrate knowledge, now we have to actively do something with it. Be able to demonstrate skills in the provision of culturally informed services. So we learn about it, we ask about them, but we know it and we practice it on a regular basis. So, and then here we go, here's the bigger one. Those of us that are in our nice little comfortable private practices, right, working in our with our micro level clients, social workers must take action against oppression, racism, discrimination, and inequities and acknowledge personal privilege. How about that? I'm kind of wondering why NASW thinks they have to be so specific about this. I do. I kind of wonder, some of you that are in the room, aren't you kind of thinking, well, duh. You know, we learned this for 2 years in our graduate program, but they're asking us to take it a step further. This was all new and added in the 21 revision. We didn't have to actively before we didn't have to take action against oppression, racism, discrimination, inequities. We didn't have to necessarily acknowledge our privilege. Now we have to. So I was honestly, when I was putting this together, I went online to look for some fun memes and pictures to put in. Wow. I saw more memes about Black privilege. And I just thought, our society hasn't learned anything. I thought, you've got to be kidding. It was very, so we're going to look at this instead. There's no cute memes. Instead, we're going to look at this little model. And this is a good way to explain privilege, because I didn't understand privilege until I finished my undergraduate degree, and I had a professor at UVU who it was like, my mind was blown. That's what privilege is? So I have friends down in Texas that post memes on Facebook that say things like, and I quote, and excuse the language, I never had privilege. I worked my ass off for everything I have. Is that privilege? Do they get privilege? No, it's not what privilege is. Okay, so here we go. Privilege. You have advantages that others don't, and you didn't do anything on your own to get it. It just comes as part of the package of who you are. The coin, two sides of the same coin, right? The social structure that produces and maintains inequality. Our society, our government has a very difficult time with that right now, right? If you watch the news, there's not a lot of accepting responsibility. It's more excuse making and no, it's not like that. Okay, so sexism, racism, and ableism. Women that are in here, have you been paid less than your male counterparts? Yes, you have. I know you have. I was too. Bottom of the coin, right? You have disadvantage that others don't. And you didn't earn it, and you have it because of who you are. Can you see how that's two sides of the same coin? So at A&M Texarkana, I am the only, well, now that UVU just stole one of my faculty members, so I will be the only white person in the department. And I've had a lot of conversations with my African American colleagues because I'm comfortable enough with them to ask. And I say, please, I'm from Utah. Utah is fairly homogeneous. I said, please help me understand. So we went through the whole George Floyd thing. When that happened, I asked questions because I felt comfortable asking. I'm hoping that you all work with colleagues that if they're of a different culture, you feel comfortable asking. So I learned a lot from these wonderful people that I work with. But I've never had to worry about wearing a hoodie. In Texarkana, you don't wear a hoodie with the hood up. Doesn't matter what race you are, there will be an assumption. So my hoodies, I have 2 of them and they stay in my closet and I won't ever pull them out when I'm there. How sad is that I have friends that can't wear hoodies. I choose not to, but they don't have the choice. Okay, here we go. Now, this is where you have to look inside. It isn't enough to just do the checklisty stuff. Social workers should demonstrate awareness and cultural humility by engaging in critical self-reflection. How often do you think about your own privilege? How often do you think about what you know about other cultures? How often do you re-examine how you engage with clients that are of other cultures? And understanding and accepting your own bias, and we all have them, right? We all have them, and engaging in self-correction. This takes humility. This takes a lot of humility. It's not easy to say, well, okay, so I might as well just be vulnerable and open because we're in a little rental unit and it's in a sketchy neighborhood. And I caught myself using a microaggression, even though I just took a diversity in higher education course, and I said, we live in this real ghetto neighborhood. Okay, I haven't even met most of my neighbors. I've lived there now for a month and a half, and I've met the people that on the other side of our duplex, and then a guy across the street. And immediately what comes to mind when I see Trump 2024, stop the bullshit, I think, really? And then I realize, oh yeah, I've got to build bridges. I have to understand why they think the way they do. I have to engage in critical self-reflection. So we all have to do that. And we all have inner racism. And there's no shame in that as long as you acknowledge it and you work to correct it. So do you see how social workers have to take this a step further? This is not to say that marriage and family therapists and counselors are off the hook. Your ethical codes just aren't that specific. But the same applies. We all should be doing this regardless of what our profession is. So we have to learn. If there's something we don't learn, we need to go and get some training and education on it. And there's plenty of it online. There's no excuse. We can't say, well, I just haven't had time. Stop. You know what you need to do, and if you need to do it. So what steps are you going to take to improve your cultural humility? I'm going to give you a minute just to think about it. And those of you that are taking notes because you're trying to look busy, I get it. You're writing a letter to your grandchild or what. But if you are just kind of jotting down notes about things that maybe make sense for you, what is something you can do to improve your cultural humility? I would invite you to set a goal. Okay, let's talk about technology. That was the third area that the NASW Code of Ethics made a big deal about. Okay, so what does the American Counseling Association say? Notice that there's not a whole lot because they haven't updated theirs since 2014. I'm sure there's something coming. Counselors will develop competence with the use of technology when using for teaching or supervision, etc. Develop competency in the knowledge and delivery of counseling services, and that's straight across the board. Psychologists have the same thing, social workers have the same thing. And make clear, and this is huge, make clear technical policies are addressed in your informed consent document. That's gonna cover you if everything is clear. So what's gonna happen if you're in the middle of a session and the internet drops? What's the procedure? What's the process? You've got something in your informed consent that explains what the next step is, what you're gonna do, how often they can contact you. Counselors discuss and establish professional boundaries when you're working with people online. Do you notice, though, it's not really specific? I kind of appreciate the counseling profession that they kind of expect that their counselors just get it. And then counselors make reasonable effort to make sure that their clients can handle this kind of stuff, that they're tech savvy enough to do it, that they understand tech language, and that whatever platform you're using to engage in counseling with them, that they can understand and maneuver it. APA. This one I do have to chuckle because they don't have a lot. So most of it is, this is what we do, but there's not a lot of, here's what you can and cannot do. MFTs have an entire section in their code of ethics for technology. So yay for MFTs. They may not have anything on self-care, but they rock when it comes to the technology part. And they're short, sweet, and to the point. So they're very wise about making sure they're in place, in tune with the laws and rules about how to use technology, what jurisdiction you can. I live literally on the Texas-Arkansas border. So I can go for a run in the morning and I can run to another state. That sounds impressive, doesn't it? Until you realize how close it is. It's the Twin Cities. And Arkansas policies are very different from Texas. And if you license in both, that's really nice, but they're very different. Ugh. Okay. Informed consent, you understand the laws. And I love this. You have to be careful about the tech platform that you use. So, what are you using? Are you using FaceTime? Zoom? I'm sorry? What's it called? Doxy? Simple Practice? Okay. So you're all nodding, I'm assuming. How many of you had to do virtual once COVID hit, that you had to shift your practice and you had to start doing things virtually? Was it a kind of a tough shift? Some of you aren't raising your hands, so not everybody had to shift. Lucky that you didn't have to. I have a part-time private practice, and I just put it on pause for everybody but one, and that's because she was not going to have it. Unfortunately, she lived in Texas, so I could do that. They want you to be competent in what you use. All this stuff makes sense, doesn't it? This is all very logical and very trusting. So those of you from counseling, APA, the psychologists, and marriage and family therapists, your governing bodies assume that you don't need to be micromanaged and have everything explained. Not so with social work. And I'm trying really hard to be patient with the NASW, but it must be because we're not doing it right. Why else do they make policies like this, right? Okay, so social workers, we're aware. We're supposed to be aware of cultural situations with people so that we're able to make sure we understand what they can have, what they have access to and what they don't. We really have to kind of dig a little deeper. And we have to go a step further by seeking to prevent those barriers. So at Texarkana, this area that I live in, sometimes I scratch my head because we have a whole area in Arkansas where the school district is not allowed to give homework because too many of the homes don't have electricity to have lights on at night to study. And this is America? I mean, I thought, really? Are you kidding? There's a friend of mine who teaches in that district. Okay, so we're supposed to prevent those barriers. How do we help our clients that don't have electricity, obviously can't plug in a computer? See, we have to take this a step further. It's not just acknowledging that there's a problem, it's doing something about it. And we're asked to assess where they are. We assess that cultural competency type stuff. Look at all these areas: environmental, economic, mental or physical ability, linguistic. We have to assess all that before we determine whether or not virtual or electronic practice is even gonna work. And then we have to advocate for change. So we've had a lot of mental health providers. So we have tons of counselors in Texarkana. That's kind of the ruling, kind of like in here, it's a lot of social workers. In Texarkana, it would be counselors. And not very many social workers at all. So but our counseling siblings are having to do the same type of thing. They're having to engage in social work. I have a dear friend who just finished the counseling program down there at A&M, and she said, in both of my placements, in my field placements, she said, I've had to do social work. I don't want to do social work. I want to be a therapist. Well, when that's the work that has to be done, you're going to be doing social work. It's kind of like Maslow's hierarchy, right? You can't do therapy with somebody that can't access the basic needs. I'm so sorry that we have to spell this out. Stop gossiping about your coworkers online. Don't you love that? Avoid unwarranted negative criticism of colleagues. The addition this time, we've always had this in here, it's under respect, in the respect for colleagues section. In verbal, written, and electronic communications with clients. Why would you say something about one of your colleagues negatively to a client? I mean, doesn't that just sound like, well, duh? What are we doing wrong that this has to be spelled out? And we want to make sure that we're not pulling out in our criticisms, that we're not targeting the diversity. And don't sext your clients. Yeah. No words. Would that kind of be what this is? I'm just asking. Is that kind of what it's saying here? Don't be doing that kind of stuff with clients, right? Or students, or your your staff. Just so you know, ACA, APA, and AAMFT don't have that. do we? For those of you that are social workers, I'm asking that. I'm thinking, why do they have to spell it out like that? Because obviously somebody has had a problem with it, right? Isn't that why rules are made? Because somebody did something to mess that up. Okay, also, don't sexually harass electronically. You know, we act like this is a real surprise, but how many of you know of people who do this? Yeah, we do, we know. And sometimes it's hard to come forward and say, hey, but that's another new thing that just came out, is that we are supposed to also babysit our colleagues. It doesn't use the word babysit. It just says that we're to bring to attention people who are doing this. Are you comfortable with that? Are you comfortable kind of saying, did you know that she's sexting that other guy down the hall? I just want you to know because you should know. Okay, I make light of it. You know what the chain of command is, the reporting lines, that kind of stuff in your organization. And I'm sorry that we have to have this. But because it is so prevalent, we have people who are losing their licenses all the time because they're doing this kind of stuff. So last night, my husband and I had dinner with his son, who just had a sexual harassment training. And he said that a third of the people in the sexual harassment training were saying, this is stupid, we don't need to have this. Why can't people just toughen up? Really? Any ladies in here don't feel tough? What? Yeah, no words. But that's the problem. It's so commonplace and it's so accepted in so many places. Me Too didn't do enough. It's a work in progress. So you want to be really careful about this, simply because it's more common than people think. It's more problematic than people think, and fewer people are not speaking up. People are starting to speak up about this. Yeah, see? So not only is it enough not to do it yourself, but you also need to take adequate measures. You have to decide what adequate measures are, but adequate measures to discourage, prevent, expose. How about that one? Expose and correct the unethical conduct of colleagues using technology. So pick one of those: discourage, prevent, expose, and correct. What do you think that means for you? Anybody have a thought about that? All right, Dorothy, I can pick on you because you're a former student. And I feel comfortable picking on my former students. You know what? It's totally okay. I just want to know that if we were working together, would you take adequate measures to discourage me? Oh. But if I was behaving inappropriately, would you feel comfortable taking some kind of action? Why not?
Because I know you a little bit more than just like some random person.
Okay, so if you know somebody, it's harder. It's harder to do that, isn't it? Sure, it is. Why else might you? Yes. You're off the hook now. You're welcome.
Even if you do your part to try to expose it to your supervisors, you may not trust that they'll do anything about it.
Does that ever happen?
Yeah.
Ooh, he just said, say that again.
It might be the supervisor you have to talk about.
That's sticky, isn't it? What else might you be concerned about that might keep you from actually taking some kind of action, whatever that looks like? Backlash, a little retaliation? No, come on, we're therapists. We don't do that kind of stuff.
Stirring the pot.
Oh, yeah, because then it makes the whole work atmosphere a little awkward, doesn't it? And uncomfortable, especially if you can't be anonymous about it. Wow, there's like 100 different reasons why 210A is not easy. Not easy. Okay. Don't engage in dual or multiple relationships with supervisees, and the dots mean because it's this for the same reasons as down here. If you're a teacher or a supervisor, you don't engage in multiple relationships. Now you would think that that's like, well, duh. My dearest friend in Texarkana is a counselor, and she got her license suspended because she had a client, she changed employment settings, and there was a client she wanted to take with her. And she got permission from both agencies, assuming she would do it on her lunch hour, because she was now at a different setting where she couldn't just bring somebody over. Well, she just loves everybody. And she wanted to help this sweet woman client because she was struggling financially, so she bought her some groceries. And then she went out of town for a little bit, and she invited this client to house sit for her. And then, in her new place of employment, her colleagues, even though she was the director, she never asserted any type of authority, so they were all it was an egalitarian kind of a setting. The other two, there were 3 of them, that's never a good number. Have you noticed that? There's always 2 against 1, always. So the other 2 turned her in for seeing this other woman because she had to do it during a work hour. So she was fired, and then the other 2 weren't happy enough with her just getting fired, so they turned her into the licensing board. The licensing board took 2 years to act on it. So she wisely, from the moment she got fired, she immediately hired a supervisor so she could have weekly supervision, and she took ethics training. So 2 years later, she's had 2 years of supervision and 2 years of ethics training. She goes before the licensing board, and they suspend her for 3 years. ACA is different than the counseling board, is different than the social work board, and I've learned this. It may not be the same way here, but in where I'm at, the counseling board is more punitive, the social work board is more developmental. They want to work with you, they want to teach you, they want you to learn from this experience. The counselors are like, we have to protect the profession. You're out. This is probably one of the nicest people you'd meet. She'd sit right here among you. You all would love her. You'd never know. But it's easy to fall into these kinds of traps. We all think of the real dramatic stuff, like the sleeping with your client scenario. That one's that's a no-brainer, but some of these things, oh, but I really cared about her, I really wanted to help her, and then she couldn't make the lunchtime, so I brought her in at 3. And the other 2 were, yeah. So yes, there's reason to consider backlash, retaliation, uncomfortable work environment. What if it's your supervisor? She was the supervisor. So those are all legitimate reasons why you could be nervous about that. Okay, and then here's my personal favorite. Avoid dual relationships that may arise while using social networking sites or other electronic media. How many of you have had clients try to friend you on Facebook? Happens all the time, doesn't it? Sure. I'm hoping you say no. Just saying that. If you want to connect with clients over social media, I hope you have 2 different sites. You have a personal and a professional page, right? Say yes, yes, that's exactly what I do. Thank you, I'll feel better. Yes, have separate ones. Don't be friendly. Then they see stuff you don't want to, that you may not want them to see. Have you ever wanted to check out a client on Facebook? Search them? Never wanted to? Just to check it out? I mean, if you look somebody up on Facebook, you can see kind of, you learn a lot about their life depending on how much access you have. And there's a lot of stuff in there. And some of you are going, no way. Good, because that's unethical. I didn't even know that. So when I was at Genesis Prime Care, I had a client that came in and he snowed me so good. He snowed me, wow. He gets an Oscar. So he came in, he wanted to have weight loss surgery, and the physician said, you have to go see a therapist to get clearance. So we met, 8 or 9 times, and what a neat guy. And we talked, and, I did the best I could to assess and evaluate, and then I wrote the letter for his doctor. I'll never do it again, never. I'll send them out to a specialist. Yeah, I'll send him out to a specialist. So one of my coworkers comes in and says, how long have you been seeing him? And I said, well, it's been 7 or 8 visits. I just gave him a letter so he can get weight loss surgery. And she said, oh my gosh. And she pulls him up on Facebook. Okay, so I didn't know he was a convicted pedophile, had a very long track record of problems. I mean, there was just so much stuff I didn't know. So imagine the things you can find out about your clients if you just stalk them on social media. You could find out really good stuff, couldn't you? Yeah, no, not without their permission. Dang it. That's actually kind of nice, though. Yes, ma'am. Well, it's kind of like pornography with men. You don't have to go looking for it. It comes and finds you, doesn't it? Yeah. So what happens here? So what are your thoughts? What if it's something that just pops up? There it is. What? So you can just shut it down. Okay. It does happen. Okay. Well, what if it's something concerning? You didn't go out looking for it, but it came and found you, and it's concerning. It kind of depends what the situation is, doesn't it? We'll go through the ethical network in just a minute, the framework, and hopefully that will help. But it's our responsibility. So those of you who are supervising students or teaching classes with students, it's your responsibility to set those appropriate boundaries. It's not the students, it's yours. Okay, so now here's another thought to consider. Do you use technology in your practice? How much do you use it? And to what extent? And what steps can you take that will protect your clients, but will protect you? And will be within the bounds of whichever professional guidelines you're getting, you lucky counselors and marriage and family therapists. Although, I don't mind, I like following rules if they're really specific. If I know what they are, then I know what not to do or what to do. Sometimes the gray area is just a little too gray. All right, let's give you 10 minutes. So you can check your email, you can do whatever you like. 10 minutes, take a breather.
2.
Okay. I love socializing just as much. Just a couple of things. I want you, and this is a somatic experiencing training coming out in me, but I want you to honor your body. So if you need to get up and stretch or go to the back of the room or sit against the wall, just do it. It's okay. I just want you to be as comfortable as you can and take care of whatever your needs are. Okay, ethical models of decision making. So in preparing for this, I read like 12. I didn't know there were so many out there. There are tons of them out there. In fact, if you are from the American Counseling Association, you counselor types out here, you have a model. And part of your ethical standard is that you will use a model in order to solve ethical issues. Okay? So when counselors are faced with an ethical dilemma, they use and document as appropriate any ethical decision-making model. So in other words, the big deal is to have a process of some sort. It doesn't have to be one specific one. You just have to identify the one that you're using, and it will save you legally so much. So look at all the things, though, that they ask that you look at. Consultation, right? Your own ethical standards, principles. I'm going to show you some of those in a moment. Local laws. Yeah, so in other words, whatever ethical model of decision making you have, it's going to have to be fairly comprehensive. Now, ours isn't quite as detailed, but I'm tired of speaking. Would you read that for me, please?
I don't have one device.
Okay, I should ask for volunteers. Nope, that's okay. Does somebody want to read this for me so I don't have to? Thank you. Okay, now we do have Aaron. Where's Aaron? Aaron is going to be our microphone man, so if you want to, thank you. And then after we do this, we do have a question that we will also answer.
Is it working? Oh, yeah. Okay. In addition to examining relevant legal issues and their compatibility with social work's ethical standards, social workers should try to draw on relevant ethical theories, principles, and guidelines. These can help social workers conceptualize more clearly the ways their professional duties may conflict and may help them identify potential resolutions of these ethical dilemmas.
And just imagine right after that it says, and keep you out of the doppel complaint. Okay? If you have a specific way of how you go through your taking an ethical dilemma, if you have a specific process, you're going to be covered. That's the important thing. Okay, so ethical principles, when it talks about specifically ethical principles, they're kind of ranked in an order here. So, you want to give us the first one?
Sure. Do not harm.
Okay, so do no harm. Doesn't that kind of sound like duh, right? How about, would you kindly read all these?
Oh, protect the integrity of the profession.
Okay, isn't that amazing that that's right up there? But you have to. You are safeguarding the reputation of the profession that you subscribe to.
Client autonomy.
Okay, client autonomy. So we care about clients being able to make their own choices and their own decisions.
Promotion of growth.
Okay.
Clinician autonomy.
Why is it that we're at the end? We're at the bottom of the food chain here. I like having autonomy as much as anybody, but obviously our clients are more important. That's why we're in it, right? Okay, so let's look at, there are some models out there, and I'm serious. If you Google ethical models of decision making, you'll come up with a ton of them. There's tons. So I wanted to narrow it down because ACA has one that they subscribe to. So those of you who are counselors in here, I don't know if this is the one that you use because you don't have to use that one, but this is their suggested model. First of all, identify the problem. And by identifying the problem, it also means making sure that there is an ethical issue involved. When you identify a problem, you have to kind of pick it apart a bit. Apply the code of ethics. That comes next. Then determine the nature of the dimensions of the, okay, so that's when you're really spreading it all out. What does it look like? We're going to look at it from a legal perspective. We're going to look at it from the client's health, maximizing choices, all of those things. Then you get your list of what are the possible things we can do? How can we resolve this? Consider the potential consequences, right? So you look at each one, the old pros and cons list thing comes out. And what's going to happen if we do this versus we don't do this? Evaluate what you choose, and then you do it. So ACA, yay for you. It lacks something, so this is not my favorite model. So I looked at a bunch, and this was my favorite. And this is what I'm going to go with forevermore, henceforth. But Frederick Reamer, for those of you that have gone, had an ethics class lately, Frederick Reamer is one of the premier writers on ethical issues. Him, and there's also Alan Barsky, so if he's got anything, you can pretty much trust whatever these guys say. So here's the first step in this ethics decision-making framework. It's too bad it doesn't have a title, so we'll just call it the Reamer model for today. Let's look at step 1. And I want you to think, if you've got one in mind, if there's an ethical dilemma you're kind of wrestling with right now, a case that maybe is making you a little nuts, kind of see how this framework, how you can fit that problem and resolve it through this framework. Kelsey, will you read that first step?
Yes. Step 1, identify the ethical issues, including the profession's values and duties that conflict.
Okay, so roll that around in your head for just a minute, and if you've got an ethical issue in mind, can you see how that might work? Because you can pretty well tease them out. Gee, is that a confidentiality issue? Is that a client right to self-determination issue? Pull all of those out. Okay. Second one. Would you? Yes, I would love to.
Step 2, identify the individuals, groups, and organizations likely to be affected by the ethical decision.
This is very social worky, because usually when you're doing micro work, I'm sorry, I'm driving you guys nuts, I'm sure. Sorry. I'm mobile by nature. So in social work, we're not looking at just the person. We have to look at other things that are impacted too. How about the family, which of course other clinicians think about that. But what other groups? How about organizations? What is this going to look like from a micro, meso, and macro point of view? Who's going to be impacted? Okay, now look at all the possibilities. This is the fun part. This is the happy part, right? All of the things that we could do to make this work. In fact, how about if we just read it? Will you be kind enough to read?
Step 3, tentatively identify all viable courses of action and the participants involved in each, along with the potential benefits and risks for each.
Okay. This is where you really get to use your creativity and your flexibility, because you've really got to kind of pick this out. Will this work? How about this? Brainstorming like crazy. Erin, I'm sorry, I'm not even letting you do your job. Let me stand up here, and I'll let you find somebody to help read the next one, okay? Okay, step 4. I love it. I'm not doing it. You do it.
Thoroughly examine the reasons in favor of and against each course of action, considering relevant codes of ethics and legal principles, ethical theories and principles, social work practice theory and principles, relevant laws, policies, and practice standards, and personal values and value conflicts.
That's a lot, isn't it? Does it now kind of feel like, never mind, I'm going to go with my gut? When you start looking at this, it's like, really? This is really complex. But these will come out because you're used to working and evaluating these kinds of things in your daily work all the time. So this may be a little easier than you think. However, it's going to require a little time, and you're going to want to write it down. Because if Doppel comes knocking on your door, you need to have a defense. And your documentation is going to be your defense. Okay, next one.
Step 5, whoa. Consult with colleagues, supervisors, and appropriate experts.
Okay, this is one step that I noticed the ACA does not have. And you want to consult. You want to consult. You want to talk to your colleague or a supervisor, somebody that you trust that will help you look at this from another direction. And if you, of course, you're going to remove the personal identifying information, right? But the general concepts of what's happening, you want to bounce off of somebody else. Because if you get pulled into Doppel, you've got somebody else to say, yeah, we actually talked about this and we looked at what all the options are. When you go to Doppel, it's not going to be, did you do the right thing? It's going to be, what process did you use to come to the decision that you did? Okay, step 6.
Make the decision and document the decision-making process.
Document, right? You got to write it down. That, to this day, I remember a patient that I had when I worked in the emergency room, and I know there's some of you in here, former students that work in the ER. It makes me so proud. So I worked in the ER, and I had a woman who was suicidal, and she came in, and I worked with her, and we did a plan and all that kind of stuff, and I sent her home with a plan. And then, wisely, I'm so glad I did this, I really wrote out exactly what I did and why. Well, 4 days later, her husband comes back into he doesn't come to the ER, but he comes to our department, and he says, I want to lodge a complaint. I don't think my wife got good care. I did send her home that night, but we went through all the steps and talked about everything. And so they called me in, and they said, okay, we have a problem. I said, well, okay, let's pull the chart. There it was in all its glory, the plan, explained completely why, and that the client was okay with it, that the client bought in. And that was the end of it. It didn't go anywhere because I had documented everything. So that's why step 6 is so important. When you make the decision, that's part of it, but you've got to explain it and put it in the chart or the file. Okay.
Monitor, evaluate, and document the decision.
Oh, there's that document word again. Okay, when we talk about monitor, right, you're going to want to see how that works and then evaluate it. By the time this ethical dilemma has been resolved, how did it work out? Did you figure it out enough so that when you evaluate it, would you go back and do the same thing? Would you like to go back and do something different? It's okay. You're not expected to be perfect. But now once you learn from it, then that narrows down what you would do the next time. So that evaluation piece is really key. If you document that, it's all in there. It's your life and license preserver, that kind of documentation. And I always, this is me, if I have a secure setup in my office, I keep a hard copy. I know some of you young people are like, really? That's so archaic. It is. But I've lost technical access when I needed it the most, so I always keep a hard copy of important stuff. Okay. So that's 7 steps. Think of that for just a minute, and now one more, a model. So how do you decide which ethical principle takes precedence? Because when you're looking and you're evaluating, which piece is most important? So there's a lot of them out there. I like this one, an ethics screen that you can look at. So it is rank ordered of which values or ethical principles are most important that these authors have decided. But they were the same as another one as I was reading, and I thought, okay, second witness, I'll go with that. But it isn't the only one out there. So use what works for you, plus your agency may have, there might be processes in there that are different. Okay, so this is the principle. So the first one, the most important of all of them, is that people have the right to live, to be alive, to exist, and to have their basic needs met. Think of the foundation of Maslow's hierarchy, right? You can't deal with the other stuff until basic human needs are met first. Second one is that treatment is fair, that everybody has access to it, that they have what they need, that they can get what they need. It's fair and it's equal. Okay, how about the third one?
You bet. Have free choice and freedom.
Ooh, I like freedom. Isn't it funny? We really value that in our culture, but it's only third down the list. Okay, so choice, having options is pretty sweet. Okay, Erin, I'm going to let you do your job. Somebody can do number 4.
Injury that is minimal or non-existent.
That's just a little concerning to me, that it's 4th down and it can hurt a little bit. I'm not sure about that one. Actually, it's okay. You want to protect the life and health of your clients, and you want them to have access to what they need. Okay, number 5.
Cultivate a good quality of life.
We all want that. I'm not sure I think that that's more important than number 6. Number 6.
Secure their privacy and confidentiality.
Do you think that's more important? Yeah, some of you are like going, no, I don't think so. And then finally, the last one.
Understand the truth and all available information.
Okay. So that last one, just to put this in perspective, is those of you that maybe work with people who are a bit, that are cognitively impaired, can they understand some of the things that they should know? That's kind of where that one's going. Okay, so here's your principles. If this order doesn't work for you, find one that does. I'm not sure that the quality of life is more important than confidentiality. Confidentiality is kind of our bread and butter. But you have to decide at what point something else takes precedent over that. Okay, now it's time to do some scenario work. Time for you guys to do some work. I'm tired of talking, and I'm sure you're tired of listening, and I can't blame you. So, I'm going to give you some scenarios. Some of them are easier than others. And also, if you have one that you're wrestling with, maybe your table would like to talk about that. Before we do that, though, Alex, you had a question, right? A Zoom in, somebody put it in the chat.
Yes, we did. We had a question coming from one of our virtual attendees. It's when we were talking about social media, but I think it's a great question. Ashley asked, is it ethical if the client requests you looking at their social media page?
Is it ethical if your client asks you to look at their social media page? Okay, what do you think? Yay.
I think maybe if you viewed it with them in session, like they are showing you their social media, but you're not on your device looking at it outside of session. That's just a guess.
You second that? What do you think?
I think it's important to understand why they want you to look at the social media account. And dig into that with them, because it might be something deeper that you can actually work on with them.
Ooh, okay. Is that where you would go? Any other thoughts? You want me to do this one, Erin?
The best word in social work, it depends. What is the...
So maybe, Ashley, if you gave us a little more information, but I think the bottom line here is that you'd kind of tease it out. Thank you for sharing that. Tease it out. I have actually looked at social media with a client in session before, and that's because she does her Instagram page is all about art and all the drawings that she does, and she's amazing. So I was happy to look at that. But I've never seen anything that's been weird or controversial or anything. But yeah, if you're working with somebody who wants to show it to you, there's a reason why. You can tease that out. Okay, you ready for first scenario? And you all can bounce it off here. And if any of you have a good scenario that you want to bounce off the collective wisdom here, we will do that after we've done these. So here we go, scenario number 1. Jackie has many issues with distraction, concentration, and organization. Her desk is almost always scattered with papers. Who is in my office? Has somebody been taking pictures? She is behind in much of her documentation, and admittedly, she does not record events in client files every time she is required to document. When she does write something, the notes are, okay, I obviously took something out. They're kind of sketchy, and they're, what? Does it? Oh gosh, very brief and vague, mainly because she does not remember I have no idea what I did there, but I'll fix that. Because she does not remember the details. She routinely backdates the notes so she does not get in trouble with her boss. Is this behavior ethical? Why or why not? And you may be surprised. I know you guys are thinking this is really easy stuff. Not so much. Not so much. So talk it over. Let me throw a wrench into this for you. That's totally fine. So what are you guys thinking over here? All right, so let's hear what you all have been talking about. What is the ethical issue here? If somebody wants to raise a paw, Aaron's running around with a microphone because I'm keeping my feet glued up here. Right here.
Kris, I have a virtual attendee question.
Yes, please.
Wondering about what you would do if there's anything you need to do if you feel you might need better documentation on a past client dilemma where you no longer have access to that client's file. Is there anything you can or need to do about it now?
Okay, so that becomes then a going back in history kind of thing. I don't know everything. I wish I did. Then I fooled you nicely. What is the issue here then? And okay, let's be honest here. If we can be vulnerable for a minute, anybody ever backdated notes? Of course you have. Maybe not everybody. If you guys are all up to date all the time, yay for you. I applaud you. I have a colleague back in Texas who was leaving an agency, and they made her make up 7 months worth of notes so they could bill before she left. That was a red flag about hiring her. I said to my boss, we may want to rethink this. And she said, she's an incredible therapist. We're hiring her. Okay. So let's look at this where obviously it's a little... So what about this clinician here who does real brief, vague notes? So I listened in on some of the conversation. So what are your thoughts about this clinician? What are the ethical issues here? So she doesn't always document. And the notes are brief and vague. Anybody here write brief and vague notes? Yeah. Because what happens if it comes back to haunt you, right? You want them to be brief and vague. What else is an issue here? Okay, accuracy. Is that a problem? Mainly because she does not remember the details. What could be a problem there?
If she knows she has an issue with distraction, she should probably create some kind of documentation so that she can remember those things. And that's knowing your limitations. So that would be an ethical violation if you're having distractions and know that that's an issue for you. I mean, okay, getting vulnerable. I have a learning disability, and I know what I need to do to make sure that I get my notes. I take notes. I ask my clients if it's okay, and that's my reference. So it's knowing your limitations so that you can produce the notes that are going to be effective for your clients.
How does that sound? Why do you think this clinician may not remember stuff? I mean, she may have ADHD, right? But what else? She's overworked. She's human. What if she's cognitively impaired? Maybe she's aging. I don't remember names as well as I used to. I don't remember details as well as I used to. I used to never have to keep a calendar. I have to keep a calendar now. If she does not remember the details, could that be a problem? Okay, so now on our ethical principles screen, if we're looking at competency of a therapist, and we're looking at integrity on documentation, which carries more weight? Okay, if the clinician has a memory problem, maybe if she's cognitively impaired, or and that's why she can't remember things, or the integrity of keeping your notes up to date, which one carries the day? If you have to consider them in order when you're dealing with multiple ethical issues, which one takes priority? Okay, the latter, help me. I don't even remember what the scenario is anymore. What was my question? Who's cognitively impaired in this room, sir?
For me, it's it's continuity of care and congruence in what you're doing. And I don't like to write lots of notes. And one of the things that happened in my career is one time a client came in and had her chart. She got a copy of it. So you better be writing what you're doing, and that can happen to anybody. It's really the client's possession. They can get it anytime they want. So be congruent and write what you're doing. Don't write something in there that some thought you have about the client that you're not talking to the client about. You're in trouble.
Good points. Okay, so let's go back to that ethical screen for a second. Okay. So where would we put here the health and welfare of the clinician or the integrity of the note process? Does it fit neatly in here? What might be the issues that we're dealing with here? Does it fit?
So I'm thinking the competency could fit under treatment that is fair and equal, because other clients that might be coming into that same setting, if the other clinicians are functioning at a different level, then that treatment is not equal.
What do you think of that? Are we thinking on this one?
But so that she can get her notes done and still be successful with therapy.
You're such a humanitarian. I love that. And if you're a nice boss, that's what you do. You work with the person, right? So you may need to make accommodations. That's fair. Is it fair and equal to the client? And then does it fix the problem with the documentation? That's a good solution, and it's one you can take and defend to Doppel. Okay, let's get to the next one. By the way, I know some of you were talking about other scenarios. Is there any you want to share with the group? Or do you want to go with these that I came up with? Okay, you're nodding your head. Is that yes? Okay. All right, Jackie, we got you covered. Okay, let's have somebody else read this. Who would like to take the microphone for me? Thank you.
Donna is a resource coordinator for female victims of domestic violence through an agency that provides group interventions for men convicted of abusing these same partners. The contract the agency has with the government for the treatment of these mandated clients states that a resource coordinator must make contact or attempt to make contact with each victim at least 4 times during the 16-week program for the men. The women are not enrolled as clients with the agency, and as a result, they do not have official files. Donna is concerned, however, that if she puts her case notes from her contact with the women in the agency files of the male partners, then the men could have access to these notes if they request to view their files. Her solution is to keep the notes in an unsealed envelope clipped to the inside of each man's file. Is the solution ethical? If not, what would you do to resolve this dilemma?
Okay, let's have you talk about it at your tables and figure it out. Some of you think it's obvious. I would challenge you to look a little deeper. So go ahead and chat about it. And remember, a good ethics approach is that you're picking it all out. Okay. It's been fun to hear how you all are kind of picking this apart. So what are some of the issues that you have identified? I'm staying up here, Erin, really. I'll even sit for a minute. Not going anywhere. I heard some really rich conversation out here. Does any table want to tackle it? My personal favorite was, we're not happy with any of this. So what's the problem? What? The government's the problem? Too many rules? Okay. Where's the consent from the victim? That's a good question. Was anything mentioned about that? Okay. So but let's look at what is in here. So she's required, according to this contract, what is a therapist required to do? Make contact or attempt to make contact. Now, I haven't worked in a domestic violence setting, so I don't know, treatment setting, and so I don't know if you work with both partners. So what's she supposed to do with the partner if she makes contact? Okay, giving resources. Is that, what do you make of that? So the husband's the client, right? Is she the client? Also, yes. And I'm seeing no. So she's been asked, okay, good. We're finally getting some discussion here. Sorry, Erin, you do it. You do it. I'm over here. All right, so pick out some of these issues. I did listen to you folks.
So the fact that the victim, whatever she's called, is required to meet with the victim, that makes her somehow a client. So first of all, there ought to be a file for her. If the government contract requires that in the perpetrator's file, there's documentation, it can be simple. Met with the victim, this date, sign your name, and no other information.
Is the victim required to meet?
No, it could even just be a check mark that says attempted to meet, and that's good enough.
Ka-ching. Okay.
And there should be no, if something needs to be put in a sealed envelope, oh, that's even an unsealed envelope. Yeah, ridiculous. He should have no access to anything that she has said.
Okay, so what then would be your suggestion on how to fix the issue?
I would create a file for her because Donna is a resource coordinator for female victims as well, which makes them a client, and create a file for them.
Okay.
And even if they're not mandated to have a file for them, they could still have a file.
Okay, so this is some flexibility they can exercise on their own.
Yes. For
the purpose of maintaining confidentiality.
Mm-hmm.
Okay? Okay. Yes.
So at the VA, they have an IPV program, and they started doing a group specifically for perpetrators. And part of the program is to, I don't know very much because I'm not part of the program, but my understanding is they would meet with partners, but they're not in the system and they're not a patient. And so they're not our client, so they don't get an active charting system. So the way that they figured out was they have a piece of paper, they probably go over what it is, they meet, and then they put it in separate in a lock file cabinet is what they've created. Okay. Government at its best. So it's hard because they themselves aren't necessarily, quote, being treated per se, and they're not patients, so we can't put them in our chart system as well. And it's separate. And then anything we do with IPV, we always ask, people may have access to your records, emergency contact, spouse, whatever. Do you want this in there? And if they don't want it in there, then they will do a separate paper chart and not chart it in this computer system.
Okay, so we have two really decidedly different ways to handle this. Are both okay? Is only one okay? Because remember the whole "it depends" rule, right? Can you have a chart for somebody who's not a client? The women are not enrolled as clients with the agency. So can you have, ethically, can you have a file on a client, on the spouse? An unlabeled folder. You know, the unlabeled folder.
I don't know, but that seems like that is a policy issue that the agency has, rather than the contract saying you can't enroll them. That doesn't make any sense to me.
She's also the research coordinator for the female victims. She's the what? She's the research coordinator for the female victims resource. So she has got to have some information on her so she can provide the right resources.
Okay, so there's different ways of doing this, right? If Donna has a file on these victims and it's kept separately, double locked, is it okay?
I feel like we were talking about this. If it were me, I would want someone to ask me permission. Like, hey, we're going to have a file about the we don't have to have a file, but we're going to have a file. Are you okay with that? Like, with permission, maybe.
Ah, I want you to say that again.
If you don't keep a record, where's your documentation? Then to take back to Doppel.
Oh. All right, let's flip the coin. Is there anything wrong with any of these suggested remedies? Having a file on the wife or in a locked area, not having, they're not a client, so we don't tell them. Aaron?
I just feel like there's a huge liability and potential risk for harm for those women where you're focusing on the treatment of the perpetrators and not on the treatment of them. You're opening up a lot of trauma, and then to just maybe give them a resource, I feel like there's a big ethical issue with that.
It sounds like you're kind of like the other groups that were saying we're not happy about any of this. Okay, did I see a hand over here? Are we good? So do we just hate this all the way around? So how do we fix it? This is a real life scenario. How do we fix it? If somebody's being unethical, we need to fix it, and you got to have the process that you document. Once you do it that way, and then
maybe dual roles. Maybe considering dual roles, having a resource coordinator that works with the women, and they consult, and then having the group management, separate roles.
So could you just make it like a condition of treatment that they have to, the male perpetrators have to just waive their rights to requesting their file information? Because if you could do that, that would make it super simple. Just say, you're mandated, you have to be here, we're contracted with the government, and you just have to waive these rights to come into treatment.
can you ask a client to waive their rights? How does that feel with you in your gut? Okay, sometimes that's where the ethical issues start, the dilemmas start. When you're going, wait a second.
But what if those files are subpoenaed and go to court and then they're mixed?
Well, they are if they're clipped.
If they're not part of the designated record set, they're not subpoenable, is my understanding.
So you're okay there? This isn't so easy, is it? I mean, it just looks on the surface, oh, we just do this and this. But once you look deeper and you see what's going on and you look at other issues, there are more than one way to resolve this issue. And sure, there may be one way that's better than another, but as long as you've shown that you've gone through a framework, you're covered. That's the important thing. If you leave here with nothing else, just remember, if you've used an ethical resolution process that you've documented and that you've consulted, you're covered. Okay, does this mean Doppel can't touch you? No. But you can easily say, I've done my part, I tried my best to behave ethically, and I followed this scenario, this framework. Okay, there was somebody else?
My thought would be she's a resource coordinator in this program, so I wonder if this program could just outsource their resource coordinating to a different agency. And then you have the perpetrators or the abusers in this program, and then the resourcing happening in a completely different agency, under completely different files.
Okay, so the issue isn't just what do you do with all the little strips of paper that are clipped to the file. We're looking at a number of ethical issues here. So one of those is what he put words to it without saying it, but it's conflict of interest. Can you work with the perpetrator and the victim in the same agency? What? Some do, but it's probably not, there are probably very specific policies about that, right?
Sorry, in this case, you're not trying to work with the victim. You want to validate what the guy's saying, so you're wanting to get information to make sure that, right? Like you're.
Is that what they're doing?
Well, I would think so. Do we trust the perpetrators? I mean, we would want to get opinions from victims, right?
No. Well, it says she's the resource coordinator for female victims. So kind of like what they were saying, connecting her to the resources she needs, but maybe not being the resource for the client. So kind of like he was saying, finding resources for them outside of that specific place.
So is it possible that we're overthinking this just a little bit? Okay, maybe she's just the resource coordinator. She's not doing therapy with the victim, right? She's giving resources. And I like the idea of checkbox, yes? I saw her and gave resources. That's it. Or I also like outsourcing. All these are good ideas, and they're fine. Any one of those is an acceptable solution, as long as you've gone through a process. Does that make sense? Because, wow, we'd all have to be at the mercy of the opinions and the interpretations of a handful of people that sit on the board. And that would be frightening. So we just have to demonstrate we've done our part. Whoop. Okay, here's another one. Sione has a regular client with whom he meets every week to work on issues of passive suicidal ideation, cutting and self-mutilation. The client also emails him at work, usually once or twice a week, sending him blog entries and other postings that complain about her miserable, hopeless life. Sione does not have the knowledge or skills to encrypt his emails, and he knows that confidentiality cannot be maintained, but he presumes that his client is waiving her protection by emailing him first. He replies back to her emails with suggestions, and always a reminder to use her crisis plan if she needs it. Although he is careful not to mention the client's name when he replies, a lot of her identifying information is sent back to her over the internet, including the original email to which he responded. Is he engaging in ethical behavior? Okay, I'm going to come listen. Talk. I'm Okay, so let's consider what are the ethical issues here? What are the ethical issues that we're looking at here? You can't be wrong, okay? Trust me, it's okay.
One of the first issues we thought of was the boundary, where he's expected to be available pretty frequently to respond, and this is a difficult boundary to maintain. And there needs to be some more communication about what is appropriate communication with the therapist, and then there needs to be a discussion about what are crisis resources if the client is in crisis. If she's sending these blogs out because she wants to communicate she's in crisis, then there needs to be, okay, here's the resources for crisis.
Okay, so boundaries is a really important issue, and doesn't look like Sione here has set too many. Yeah, okay, that's a very good point. What else? What's another ethical issue here? Think social work values. Competence. What are we looking at with competence here? You got to talk into the microphone. Marnie, you're not that
loud. He needs to learn how to encrypt his emails. There's some technical issues, things that he can do in order to make it more private, and yeah.
So he needs to do a little training.
Mm-hmm.
Yeah, increase his competence. If you're going to be using technology in your practice, then it's your ethical responsibility to be competent in the use of that technology. Okay, sweet. All right, anything else here? What do you mean presumption? Oh yeah, he presumes that his client is waiving her protection. So is confidentiality a piece here? That could be kind of problematic. Okay, what else? See, there are a few. Look at his suggestions. And I got this from the table in the back there. And always a reminder to use her crisis plan if she needs it. So what are we looking at? Is she getting the right level of care? We don't really know, but that's certainly something to look at, isn't it? If he's emailing her once or twice a week, well, don't forget, use your crisis plan. What is she looking at? I mean, what might be something she's wrestling with? Yes.
Oh, if she needs that higher level of care, that means to me that she needs more sessions, and he shouldn't be providing therapy through email, even if the email is encrypted. And the suggestion seems like that he's providing therapeutic services through email, and I wouldn't go on those waters.
That's an ethical issue, isn't it? And doesn't it kind of leave him open? If she prints those out, yeah, that could be problematic. So using technology, it's not only about giving your client proper care, it's also about covering you. Nobody wants to go to Doppel. Nobody does. So when you're looking at all of those, you have to set up that hierarchy, which is the one that you want to deal with first. And I look at health and safety of the client because obviously she is in high need. But there are plenty of issues. So how you figure this out, and what are we going to do about this? If you are Sione's boss, what are you going to do? What action are you taking? Okay, you're going to give him some training. What else? He needs some training in this and in what else? And in boundaries, that's right. You don't email. And they know that after hours, this is the other option. If they need help, they go to the emergency room or they call this crisis line or, yeah, establish some really clear boundaries. I'm wondering what the agency policy is on this. Okay, we have time for one more, so let's bust one more out here. Oh my gosh, this is my favorite. So Phineas is a social worker who provides general counseling to individuals and couples. One of his clients wanted his lawyer to obtain a copy of the social work assessment on him that Phineas had recently finished writing up. The client signed a release to allow this disclosure and then gave Phineas a business card with the lawyer's name and fax number on it. Phineas didn't look at the card other than to take down the fax number. It was only after Phineas faxed the report that the client realized that he had given Phineas the card for his estranged wife's lawyer, with whom he was in litigation, instead of his own lawyer's card. Based on the info, I just want to know why he had his ex-wife's lawyer's card. I don't know. Maybe. So based on the information disclosed in the report, his estranged wife's lawyer boosted the amount claimed for alimony and child support by 100%. The client is now furious with Phineas. This is a true story, folks, so help me out here. This isn't me. This is a colleague. So, was Phineas's behavior ethical? Let's talk about that in your tables. What's the ethical issues here? Okay, so what are the ethical issues here in our final minute, couple minutes together?
Usually release forms have name, phone number, email address on them, so he should have just used that to contact rather than the card, because then if the client accidentally wrote the wrong information, then the client has released that information to the therapist.
Okay, yeah, so if the documentation had been really clean and the client filled it out, so who's responsible? Not in the client's mind. Mhm. Except it went to him. Well, I can tell you this much right now, somebody's getting a whole lot more alimony than they were getting. Yeah, it's true. It's true. Remember, we are all about the documentation here. If you document it cleanly, you're okay. A business card doesn't count, even if you take a picture of it. Screenshot it, doesn't matter. Get them to write it on the paper. And then you have no liability at all. So informed consent's huge, release of information is huge, all of those kinds of things that are designed to cover your fanny. And even though all the amount of paperwork is a real pain, in the end, it saves you. And we need you in the profession. You're good at what you do. You have to be. I know most of you who have been trained. But I mean, you're needed. Your workloads have increased. You got to get your self-care in. All these things. Thank you for letting me come and visit with you today. I'm hoping, if you have any other questions, holler, but you guys get it. Cover yourself, have a framework that you work from, and then if you follow that, document everything, you should be okay. Most of the time, that will be enough with Doppel. But again, everything's about it depends, right? I always consult. Okay, thanks so much, folks. Have a good day.
All right, thank you, Dr. Doty-Yells. What a wonderful presentation. Very relevant and current information. Sure appreciate it. Just a couple things real quick. You have the evaluation forms, hopefully at your table. Fill these out and turn them in this back table and pick up your CEUs. For lunch, you can see there's 2 doors here. If you can head out to the left, grab your food, and when you're coming back in, come in the door on the right. Hopefully that'll help with some traffic. Again, for our virtual attendees, there will be a link, the evaluation sent to you. Fill that out, and your CEUs will be sent to you as well. Thank you.
I pick up a broken comb, run it through my thin gray hair. Though I don't have any plans tonight.
Portion of the training. Just a reminder, you should have, if you attended the morning conference, morning session, you should have turned in a feedback form and received your CEU certificate. That'll be the same process for this afternoon. We'll hand out a separate feedback form, and that applies to you attending virtually as well through email. It's my pleasure today to introduce Dr. Greg Hudnall, and many of you know him. He's been graciously providing these suicide prevention training for years here at Scenic View Academy, and we are good friends with Greg and Hope for Utah. Dr. Gregory Hudnall is a former high school principal and associate superintendent with the Provo City School District. He's been involved with suicide prevention for the past 30 years. For over 15 years, Dr. Hudnall led a statewide volunteer suicide crisis team that has responded to over 50 youth suicides. And under Greg's direction, over 75,000 people nationwide have been trained in suicide prevention, intervention, and postvention. Without further ado, we'll hand it over to Greg.
I won't mention that that's one of my former students who was always late, so that's why we're starting late. I didn't want to rub that in. Pleasure to be here. Scenic View is just an amazing place. We have offices upstairs, and we just enjoy being here. So it's a pleasure to take a couple of hours to be with you. Let me just share a couple of thoughts. Many of you are probably more expert than I am in many of these areas. As a high school principal, I lost 5 kids to suicide, spoke at 3 of their funerals. And then I was contacted by the Provo police to come down and identify the body of a 14-year-old who had taken his life because he didn't have any identification on him. And when we finished moving the body, I literally walked to my car and threw up and sobbed and made a vow that I would do everything I could to help prevent suicide. Ken at the time was a school board member, and they were very gracious to allow me to start working on different projects and different things that way. I have a master's in education, being a high school principal, but I saw the needs of my students and my family, so I actually went back and got my MSW from the University of Utah. Spent 5 years, bless you, go Utes. Be careful, I don't want my tires sliced or anything that way. But I spent 5 years working at Orem Community Hospital with Dr. Scott Boyle, and in the emergency room working with kids that were suicidal, working with families. So I know what you're going through, and I know a little bit about the personal touch. And then, as was mentioned, we started a crisis team. And some of those amazing members, Cindy and I cannot share with you the number of nights that we traveled the country. Joy, sorry. Why do I want to call you Cindy? Anyway, Joy and I and Kathy Bledsoe and others, we unfortunately dealt with over 50 youth suicides across the state of Utah, including a 4th grader who took his life on campus. We were there with the body, with the family, and it was horrendous. So you're going to get the expertise from that perception. Doug, you were out. I mentioned how gracious you were to invite us to come here and have our offices. So, and we're still friends, so that says a lot. I had back surgery going into COVID. I had rebars put in my back, so I have screws and other things. So if I walk funny or act funny, I blame it on that. And because they're titanium, I don't set off the airport alarm or anything that way. As mentioned, we've trained over 75,000 people now, and it doesn't matter who you are. Everyone is affected by suicide anymore. So the discussions today are going to be twofold. One, I'm gonna walk you through 4 different areas that I think are critical. But I've also put in some videos because I travel the country speaking at national conferences. I was invited to speak in Northern Ireland last year at the World Health Organization on suicide. We were actually invited, NATO invited us to come and speak in London, which I unfortunately couldn't make. We were invited to present to the Minister of Education in Madrid, Spain. They wined and dined us for about 4 days, and my wife said, I don't want to go home. Let's just stay here, right? My wife is a therapist for the VA, specializes in PTSD. So some of you may be affected, and if it triggers something and you need to step out, please do. Let us know if there's anything that we can do to help. I know there are many therapists here. I presented in New York City at the World Conference of Psychiatry, and when I started, there were about 400 psychiatrists in front of me, and I started out by saying, look, what I would appreciate is if you would either look to the left or the right or look at the ceiling, but I don't want to be flipping analyze the entire 50 minutes, so be kind, will you? And I would say the same thing about you therapists. I would also say I have some dear friends that are here that have already threatened that they're going to heckle me, so just ignore the jerks in the back, all right? So the other part of it is I've noticed that when I present in breakouts at conferences, the room next to us is laughing and clapping and having so much fun. I just presented in Nashville to the American Association of School Superintendents and School Board members. So I'm in my breakout with about 100 people, and they're sitting like you, just really? I mean, you know, and in fact, some tears will be shed. And the room next to us is just jumping up and down and screaming, and the breakout is over. They walk out slapping each other on the back and laughing, and everybody out of mine is walking out crying and trying to call their children to tell them how much they love them. So I've added videos so that we can spice it up a little bit, because let's just be honest with each other. It's tough out there right now. And it is tough dealing with the issues that we're dealing with, and we're going to talk about that. So I'm going to start with my all-time favorite video. So if we can get the lights, and away we go. Maybe. And there's no sound.
Hey. Hey.
I pick up a broken comb, run it through my thin gray hair. Though I don't have any plans tonight, I'm not going anywhere. Well, I should have seen this coming. Don't know why I'm surprised.
When the best rest of us steps up, our nation stands a little taller. We all play for Canada.
It's a shout out to my friends from Canada. I love the power of that, right? So here's the presentation. I'm going to bring you up to date on Hope Squad. Hope Squad is a school-based peer-to-peer program that we started in Provo 17 years ago. And unfortunately, in my district, we were averaging 1 to 2 suicides a year. And what we found out is 7 out of 10 young people before they take their lives, and when I say young people, up to age 26, 7 out of 10 young people before they take their lives will tell a friend, and then that friend won't tell an adult. So we really worked on breaking that cycle. Then we're going to focus on what we do and what we don't know about youth suicide, some of the challenges, what we have learned from the pandemic, some of the challenges with mental health. And then we're going to talk about the role of the therapist in working with suicidal clients. And then I want to end on a downer, but then try to make it an upper, talking about the state of burnout for mental health workers. So Hope Squad now, we're in 1,300 schools around the world, 36 states in Canada. We're supposed to be in Ghana in August. We're in discussions with groups in Japan, Northern Ireland, South America, Argentina with South America, and Israel and some other groups. The cool thing is we now have national officers, and these young people are amazing. You're going to see a clip next. I don't know if you saw the special on 2020 by ABC Nightly News. A couple of weeks ago, they actually interviewed a group of kids in Ohio that are on a Hope Squad. And here's the video.
What are some answers to address that?
We need to train psychologists and therapists, and we have to think about how we train families as well, including parents, in how to identify concerning symptoms. We need to support peer support programs, which are also an important part of supporting kids.
Show of hands, if you know someone that at some point has self-harmed.
Filling that gap here in Mason, Ohio, the Hope Squad.
Tons of people needed help during the pandemic.
It's our job to watch out for our peers and direct them to the help that they need.
Today they are role-playing on how to handle self-harming behavior when they spot it.
I just get really angry.
I'm here to listen to you. Like, I'm here. Or we can both go to a counselor.
What we're finding is so many of our kids want to help. They hear more so than us through social media and texting and in ways that as teachers we don't see that.
So one of the things that I want to ask is, how many of you received training in suicide prevention going through working on your degree? Raise your hand. Yeah. Unfortunately, we need to do more. I see someone kind of going, yeah, a little bit back there. It's unfortunate because how many of you have had to deal with a suicidal client? Yeah, now I see every hand. And that's reality for us, right? So what do we not know about youth suicide? And even though we talk about teens, highest rates of suicide for us in Utah right now in that age group is age 18. Think about what experiences with young people around age 18, graduating from high school, not graduating from high school, trying to figure out what their next step is, etc. So here's the scary part. And I get asked this question everywhere I go. Why is it on the rise? You know, what's happening in our society that continues to have young people see suicide as an option? CDC report, and this was pre-COVID, 2018, that young adult suicide rates have increased exponentially in the past decade. So just at your table, I want you to just take a couple minutes and ask the question. Actually, I'm gonna come to that. I'm gonna do 2 more slides. According to the report, teenage suicide rates have increased nearly 56%. Think about that, 56% from 2007 to 2018. I'm going to show you some data from the pandemic that I think will surprise you. But the rate of 6.8 deaths per 100,000 has jumped between ages of 10 and 24, has jumped to 10.8 deaths. So we're seeing this marked increase of young people taking their lives. And when you look at, this is a chart that's a little hard to see, But what we're seeing is ages 10 to 24. Now, 10-year-old is still in elementary school. Think about that for a second. We have been involved with 2 fifth-grade suicides and a 4th-grade suicide. So we have a Hope Squad program in the elementary. We've been doing it for 17 years. For 16 of those years, we were criticized, crucified by many of the national organizations. This past year, the CEO, executive director of AFSP, spent over 2 hours on the phone talking about our program. Gaga's program out of Las Vegas, Gaga's team spent over an hour on the phone with us. SOS and other programs are now seeing the importance of elementary. I love this quote by a researcher out of the University of Washington. Listen to what she says. "The truth is, anyone who says they definitely know what is causing youth suicide doesn't know what they're talking about. It's a complex problem with no easy answer so far." So, tabletop discussion. Take the next couple of minutes. You know, you're professionals. You work with kids in the trenches and adults in the trenches every day. Why do you think suicide continued to go up? Ready, go. Now, I'm a teacher, so I'm watching you, right? So please, ready, go. Okay, let's, I'm going to need a mic for this. Hey, class. Yoo-hoo! Okay, class, we have a mic. I want to take a, because we are Zooming this, and those of you that are at home, could you see, thanks for joining us. And if you have questions, let us know. But I'd like to hear a couple of comments why you think suicides continue to increase. So we have the mic right over here, so raise your hand, and there's right there. Joy, thank you.
I think it's an issue of resiliency. I mean, there are lots of issues, but one of them is resiliency. We don't teach kids to be resilient nowadays. They don't know how to fail.
Yeah.
And so then when they do, they have nothing in their tank.
Yeah, so it's a very good point. Resiliency, lack of coping skills. So one of my expertise is copycats or contagions. So I work with schools and communities when they lose number of kids. My church flew me down to California, and I was involved in an area where they lost 7 kids, Palo Alto area. Back in Indiana, I worked with a group that lost 5. Here in the state of Utah, I worked with a high school that lost 6 kids in 1 year. And can I tell you, top 2 things that I see, no coping skill, and then the second part of it, lack of resiliency, because we as adults are swooping in and not allowing our children to fail. I just did a youth conference over in Saratoga Springs, and one of the things I asked, it was to, they were secondary kids, but one of the things I asked them to do is to learn the next time you have a challenge, go to your parent, share the concern, but then say, Mom and Dad, can I try to work on this on my own? And I had this amazing young lady contact me and shared her story. We need to do more of that. Moms and dads, let your kids fail. Be there to help them pick it up. But we've lost that resiliency factor. I agree with that, Joy. One more. Someone else raise your hand. I'm going to sit. Being a professional teacher, I will wait till someone does. Please.
I think there's a lot of problems with social media, but one of the big ones I'm seeing a lot is the exposure to all the world problems.
Yeah, great comment. Exposure to all the world's problems. So I was once again doing a youth conference back in Ohio, and this young lady pointed at me and she said, "Dr. Hudnall, you don't get it." And I went, "Ooh, wow, tell me what I don't get." And she held up her phone and she taught me a great lesson. Now, I know I'm older than most of you. I told my son the other day, my grandson, that I graduated right after the Civil War. And he looked at me and he goes, "Really?" And I said, "No." But in the old days, there used to only be 3 television stations. I know most of you young people don't know that, but 2, 4, and 5. And then I see some people laughing, so they remember. And it would go off at midnight, right? And the only people that watched television were our parents and grandparents. I was raised in a small rural area outside of Nauvoo, a little farming community. My father was a farmer, my grandfather, and the only people that watched the news were them. And so when Vietnam and all the other things were happening, us kids didn't know, nor did we care. Because what were we doing? We were out doing night games. We were out playing pickup games. We were doing whatever. So this young lady holds her phone to me and she starts scrolling through and she goes, "You don't get it." I said, "Tell me what I don't get." And she said, "We can no longer trust adults." And I'm going, "Really?" And then she starts scrolling through. Teacher arrested for sexually abusing a child. Clergy arrested for sexually abusing. Shooting in Florida. I mean, just going through everything. These young people are being overwhelmed with the same depressing information that you and I see every day, that young people shouldn't have to worry about till they're out of college. And unfortunately, they're being overwhelmed. So, what's the explanation for the increase? We do know there's a rise of social media. There is no doubt that there's an impact that way. We also know that there's more demanding academic schedules in schools, both in high school, elementary, middle school, high school. I used to tutor my kids. I was pretty good with it. The other day I was sitting down with my grandson, he's in 5th grade, to help him with his math. I had to go get my wife. I couldn't figure it out. We are now increasing the levels of expectation for young people. We're taking away recess. We're taking away the things that are helping them to bond and learn how to associate with each other. And society is expecting more and more and more on the educational system. We also know that shows like Netflix, 13 Reasons Why, continue to glamorize it, right? They sensationalize suicide. But what makes this particularly difficult is the study is that there's a grain of truth to many of these explanations. If you look at Dr. Coyne's research out of BYU, heavy social media use has been linked to higher rates of depression and lower self-esteem. However, it's unknown whether social media use has any correlation with higher rates of self-harm or suicide specifically. Now, I believe it does because I've seen it. I've seen it firsthand. But the research is struggling to correlate that. 13 Reasons Why. Another study found that teenage suicide rates rose slightly following the release of it, but mostly among teenage boys and not as much among girls. Isn't that interesting? In fact, a colleague of mine that works up in Davis, right after it happened, his numbers went way up with attempts. And when they would do an assessment with the young person, they would say, "So help us understand why you attempted suicide." And the young person would say, I didn't attempt suicide. "Well, what were you doing?" "Well, I was trying to Hannah-size myself." Hannah was the star, and 13 Reasons Why, and so they've picked up off of that. And then we unfortunately know, even in our area, 3 or 4 years ago, the young lady that took her life, had her boyfriend videotape her hanging herself down in just not too far from here. But here's the thing that we have to remember. Correlation does not equal causation. And that is by far probably one of the biggest challenges for us. And most mental health experts caution against isolating one cause. In fact, if you look at the latest research out of the Center for Disease Control, and Kathy and I had a chance to spend 4 or 5 days with them in Atlanta, one of the things that they taught us is that there's about 51 or 52% of individuals that have taken their lives that we believe do not have a mental illness whatsoever. Can I tell you, I about fell out of my seat when I've heard that. Because what have we said for the last 20 years? It's depression, it's a mental illness, right? That is leading to that causation. Now they're starting to realize that there's probably more to it than what we thought of in the past. There are certain factors, such as a history of mental illness, substance use, that put young adults at increased risk of taking their own lives. We know that takes them over the edge. The mental health establishment simply doesn't have enough research to draw firm scientific conclusions about what causes the spikes. We're lucky in the state of Utah because we have an epidemiologist that is doing a psychological autopsy on every youth suicide in the state. Dr. Doug Gray did a study, a child psychiatrist out of the University of Utah, and my mentor. He did a 7-year study on youth suicides in the state, trying to find a causation. And the psychological study was actually meeting with the parents afterwards, meeting with the child's friends, even meeting with church, and then meeting with school folks to try to understand what was the trigger for that young person. And I remember him sharing a story one time that there was an individual who said it had to be the medication. But they were doing a hair follicle and a blood study, and they were finding that the individual didn't have any medication in the system. But the mother said, no, that's impossible because I saw my child take the pill every morning and every night. But what were the kids doing it? They were cheeking it, right? And then as soon as they got out of sight of their parents, they were taking it out and getting rid of it. But what did the child have in their system? Marijuana, alcohol, other things. And we know that that's that ability to push them over the edge. Our crisis team responded to a suicide in southern Utah, a beautiful young lady who took her life. Senior in high school, full ride scholarship to play volleyball at the University of Utah. She took her life, came into school the next day, put all of her journals in her boyfriend's locker, and then went upstairs to the girls' bathroom and took her life. And it literally happened that fast. A lot of people looked at it and said it was because her boyfriend dumped her. No, we know that that might have been the trigger that pushed it over, but we know that there are many more pieces to it. And suicide is so individualized, and it's one of those things that we train our Hope Squad members is that, you know, our challenge is when we're working with people that are struggling, it's like an iceberg. You know, we only get to see the top 3 or 4% of what they're really dealing with underneath. Dr. April Foreman, a psychologist and board member of AASA, regardless of what external factors may or may not be contributing, it is much more likely that there are complex things going on in society. We just don't understand suicide well enough. Isn't that interesting? We've been losing people for many, many years, and we still cannot figure out why. I think that's one of the most frightening things to me as I see the numbers increase. What are your thoughts? Take a couple of questions or comments, as long as they're not from my friends. Comments, questions? What are your thoughts? Please, yes, sir.
I just have a question about those people that try to commit suicide but end up failing. You know, what have we learned from them that might give us some clues as far as, you know, their thinking at the time or things like that?
Yeah, great question. So what are we learning from individuals that are attempting? Here's one of the things that rises to the top. They have done an assessment with over, I can't remember how many thousand. We do it in the emergency rooms. It's a cross study across the United States tracking the data. But one of the questions is, at what point did you notice that you started to struggle? And one of the things that rises to the top is that ages between 10 to 14, they noticed that they started to struggle. It's not full-blown schizophrenia, bipolar, dysthymia, or whatever, but they noticed that something was changing in their life. And the research continues, a great study out of Yale, that says if we can intervene at a younger age to help identify by educating parents, like what the Surgeon General was saying, what the warning signs are, what the risk factors, what to look for, and we can intervene early, then there's a good chance that they're not going to go on later on to take their life. But what we do know, 1 out of every 25 adults So for every adult that takes their life by suicide, 25 other adults attempt. So it's 1 to 25. 26 and under, for every young person that takes their life by suicide, there's upwards of 150 to 200 others that attempt. So we're seeing a much, much higher, and I do believe that's a direct correlation with social media, social pressure, and other things that way. Good question. Please, yes, sir.
That was my question is, is there a difference from those who complete versus those who attempt? And so if we study those who attempt, we may miss what leads to completion. And it may be something that's different.
Yeah, and that's a great question. So the question is, do we see a difference between attempters and completers? Yes, we do. If you look at Joyner's research, Joyner's one of the premier researchers, Joyner says that it takes 3 pieces, a perfect triangle to happen in order to complete. Number 1 is the individual has to feel all alone. Number 2, the individual has to feel that they are a burden. Number 3, they have to have the capacity to take their life. So when you look at individuals that have completed with the psychological study, it's individuals that have that capacity. Now, defining that capacity is the most difficult part, by far the most difficult part. I had a young man take a gun, hold it under his chin, pull the trigger, and the bullet exited his eye. He was in the hospital for about 3 months, and they asked me to work with him. So the first question I always like to start out with is, help me understand what was going on. And this is literally what he said. I got to remember it. My girlfriend broke up with me on Thursday. I figured if I killed myself on Friday, she would feel so bad over the weekend, we'd be back together on Monday. Now you and I go, wait a minute, there's something missing there. But what happens is when you're in so much pain, all you want is that pain to go away. And I think it's really important to understand is that there's 2 levels. You have the level of the individual with impulsivity. The 5th grade suicide we were involved with, impulsivity. I do not believe it was a mental illness. Then you have what my wife and others have taught me, including Dr. Gray and some others, is that you have about a 0.005% of individuals that no matter what we do are going to kill themselves. No matter what we do. So it's one of the things that I would advise you to appreciate and understand that you're going to lose a client at some time in your life. And remember, when you've done everything that you can, that individual, for whatever reason, felt that that was an option for them. Okay, so comments about what we've learned from the pandemic. And I just want to see by the raise of hand, how many of you believe suicides went up during the pandemic? Raise them high, don't be nervous. Yeah, can I tell you, I'll never forget sitting with Dr. Gray and a couple of other psychiatrists that are my mentors up at the U, who said, we were out for breakfast, Doug Kondo and Doug Gray, and they said, hang on, because this is going to turn ugly. And we really prepared ourselves that we were going to lose a lot of young people. But here's what happened. Suicides actually decreased. Amazingly, suicides decreased. 3% overall, with significant declines among both females at 8% and males at 2%. So why did suicides decrease? Number 1, kids are not being bullied in school, right? They're at home. Think how many times we close school, etc. Here's the one that we really found that stood out and was probably the most critical. Parents and families were staying home and they were reconnecting. A buddy of mine said, he goes, my company closed, we were all working from home, so he said, one morning I was rolling out the garbage at 10 a.m. on a Tuesday. He said, I was never home on a Tuesday. And I looked out at my cul-de-sac and everybody was outside doing things as a family. What did we do pre-pandemic? We got in our vans, we ran our kids to school, we ran to the activities, to their practices, to their plays, to their church events, and then we had to go do this, and then we were finally home by 10 o'clock at night. And then we were still staying up to do the homework. We lost our connection with our family. The positive that came out of it is that we were forced to spend time together. Now, if you were a dysfunctional home or a violent home, then it actually reversed, right? And those were the risk factors that we saw. But then the other thing, which really surprised us, was that families that were staying home all of a sudden started to recognize that their child was struggling. Now, there is no doubt that COVID influenced that struggle, right? Lack of opportunity to be with my peers. I'm not able to have my graduation. I'm not being able to play football, whatever it is. But for many of those that were struggling with a severe depression or other mental illness challenges, all of a sudden they're sitting there getting ready to play Monopoly, and this young child is going nuts. And the dad's going, "What the heck?" And the mom's going, "I've been telling you for 3 years, right? And you're finally home to see it." So we saw these families start to reach out to you folks to try to get help for their child. But unfortunately, not was all fun and happiness during the pandemic. 22% increase in emergency room for potential suicides by children ages 12 to 17. That trend seemed to continue into this recent year, and we haven't received the final because we're always about 2 years off. But what they're showing right now is about a 40% increase from the previous year of the pandemic. So 2020 to 2021, almost a 40% increase to the emergency rooms. Kids were hurting. The data was particularly alarming among girls ages 12 to 17. Between February 21st and March 20th, emergency department visits for potential suicide attempts it was over 50%. And we had emergency rooms that were so full, they wouldn't even allow any more kids in because of the pandemic and different things. I was involved in an emergency room situation, and I walked into the emergency room, and they had COVID patients literally laying in the hallways and stacked up. I mean, it was horrendous. And when I talked to the emergency room doctor, I said, "What are we doing about mental health patients?" And he said, "Greg, we're not taking any. We don't have room. So when they come, we're having to send them away." 1 in 4 people ages 18 to 24 seriously contemplated suicide in June. This study was done at the end of June 2021. 1 in 4 young people up to age 24. So suicide rates remain high, and they continue to climb. And we still don't know why. Now, we're not the top country. There's about 5 countries ahead of us that even have rates higher than us, with Japan way at the top. So what's the talking point I want you to walk away with? Majority of people who have lots of bad things happen or have lots of stress don't take their lives. So we know something else is happening in that brain of someone who kills themselves, and that's what Joyner talks about. Any questions on this section before we take a quick break? I'd love to hear your thoughts or your questions or your comments. Right here. Oh yeah, right there, and then right wherever you have the mic, you please.
So what stood out to me is I just finished a book called Hold On to Your Kids that talks about the shift in the last 30 years from parent-oriented attachment to peer-oriented attachment. And what stands out to me is that that very much the numbers that you're showing very much support that. And in my personal practice, what I'm noticing are the kids that have the parents that are on top of things and fully engaged, and that the kids have a good relationship with them, they're coming and telling me, they're telling their parents first that they're struggling, and then they come to see me. And those who don't talk to their parents, who can't put a parent on their emergency plan, are the ones that I am most worried about.
Yeah, that's a really good point. It goes back to what Joy was saying earlier, that the inability to psychologically deal with that pressure I was doing a presentation up north to parents, and it was a packed room like this, and a gentleman in the front row, three-piece suit, sitting there, and one of the things I challenge parents is to please take your child's phone out and put it in a charger every night at 10 p.m. So I'll say it to you parents, and I beg you to say it to your clients that you're working with. And here's why. We have kids staying up all night on their phone thinking they have to be the lifesaver for their peers. So they're not getting the sleep that they need. And we know sleep is one of the most important things for young people. So they're staying up being the therapist, being the friend, doing everything they can to try to help that child stay alive or whatever. But it's impacting them. Fascinating research that in hospice, that many times the caretaker goes first before the patient because they wear out. It's the same thing that we're seeing with our young people that are trying to take care of their peers and trying to be that caretaker are wearing out. So I was sharing this with these adults, and this gentleman sitting like right where Doug is right now, and he said, well, Dr. Hudnall, how do you expect me to take my child's phone away? So I walked over and grabbed his phone, and I said, about like that. And he goes, you don't get it. And I said, oh, here we go again. Tell me what I don't get. And he said, she'll be mad at me. And I said, do you want to be the friend or do you want to be the parent? Which then, of course, made him even that much more mad, right? And that's what we're getting. We're getting too many parents that want to be friends because they're afraid if they're not their kids' friends, then something harmful is going to happen. Yeah, good point. One other question. I saw another hand somewhere. Please, right here.
I was just curious if you could clarify. So earlier you said that suicides went down over the pandemic, and then in the last graph, it looked like it had gone up. Do you mind clarifying that?
Suicides, if you look at the 90s, late 80s, early 90s, suicides, there's a fascinating correlation between seatbelt wearing and suicide for young people, all right? So back in the early 90s, they started to do a study, and they looked at what was happening with people not wearing seatbelts. Deaths were going up like this. Why? Cars were going faster. We're building wider real estate, or highways, et cetera, and we were losing the impact, right? I mean, think about the people that die from car wrecks. So people weren't wearing their seatbelts, and deaths were going like this, and suicides were going like this. We as a society put a fortune into seatbelts, passed mandated laws. All of a sudden, deaths by seatbelts started to go down, and suicide started to go up. Now, there's a lot of variables. The federal government came out and said they branded every medication that may lead to suicide. Many family practitioners pulled away and said, liability-wise, I can't do prescriptions anymore for any kind of medication. A lot of variables that way. So then suicide started to go up, and they've increased every year, except during the pandemic window, down about 2%. Now that we're coming out of the pandemic, guess what's happening? Suicides are going up again. So I use that as a window to show a couple of things. Number one, most important thing we can do as a society is be connected. By far, we as a human being need to be connected to others. When I get pulled in by schools, faith-based groups, and others, and they present this young person who's suicidal, struggling, the first question I always ask, Johnny, can you give me the names of two of your best friends? And then Johnny will say, well, there's Billy. And then I'll ask, what's Billy's last name? I don't know. Where does Billy live? I don't know. That's not a best friend. That's a classmate. So we've lost that connectedness. Kids will show me on their phone, man, I have 300 connections, Greg. Look at all my, and I'm going, do you even know them? No. They're not having the relationship like this. So now that pandemic is over, we're starting to see the suicides go back up. Okay? Thank you for that question. All right, any others? All right, we're going to take a 5-minute break, stand up, stretch. There's chocolate in the back, run around the room, do some calisthenics. Okay, class, we're going to get started. Rock and roll. Okay, students, please take your seat. You know, as an educator, one of the things that I forgot to mention earlier is when, as a high school principal, we would always say, when the lights go off, please keep your hands to yourself. So I am a little concerned when the lights have been going down. So this is my second all-time favorite, just feel-good video.
First piece of feet, first piece of feet.
Lights. That says, but it's a great commercial. So it was probably swearing at us or something. So this is probably the meat of my presentation, and it's probably the most critical to you as a therapist. What really is the role of a therapist in working with someone who may be struggling? One of the things that I like to preach from the very beginning is to do no harm. For the last 30 years, Doug Gray and I we're the dinosaurs of suicide prevention in the state of Utah, and by far the oldest that have been doing it. And we were sitting down one time, and I was bragging about how many amazing programs there are out there. And he said, the problem is we've lost the touch of do no harm, because everybody wants to be part of it now. It's the in thing. You can get funding, you can get attention, etc. But it's also the importance of realizing that you're working with clients that are very fragile. And the challenge is you don't know at that point what their biggest struggle is. Working with suicidal clients, 71% of therapists report one client had at least attempted. 28% report having had at least one client die by suicide. Now, if you're from the VA like my wife, it's 100%, unfortunately. Skip. So what's going on in the mind of a suicidal person? The challenge is they're very divided within inside themselves. One part actually wants to live and is goal-directed and life-aiming. I can do this, right? I'm going to do this. Another part is self-critical, self-hating, and ultimately self-destructive. The ambivalence is always a factor. So I'm on the keto diet right now. I've lost about 10 pounds. I got to lose 10 more. My sugar count, because I love chocolate. I'll just be honest, right? At nighttime, half gallon of ice cream. Breakfast, potato chips, the other half of the ice cream. It's been a challenge for me ever since I was a principal. I would eat as much chocolate as the kids. And one part of me wants to do well. But when I walk by and see the Snickers and the other ones, I'm headed for that chocolate, right? So what are the warning signs for a therapist? Extreme self-hatred. And a lot of times they're telling themselves, I don't deserve to live. I'm an idiot. I'm causing the problems in my family. My medication, the challenges I'm forcing upon the rest of the family. The personalized hopelessness, we were just talking with the group over here. Nothing matters anymore. You should just kill yourself. One of the individuals who ran for Miss Utah, and she actually won 6 or 7 years ago, she came to us and said, I want to build my campaign around mental health. Will you help me? And I said, sure. So we helped her, kind of gave her some good parameters. She did a presentation to a group of college students, and it was probably the most powerful presentation I've ever seen. Beautiful young lady, 19 years old, about 6 foot blonde. She got up in front of all of these individuals and she said, I lost my father to suicide, I lost an uncle, I've lost a brother. She said, my family has dealt with severe mental illness for many, many years. She said, I struggle with depression. Every single day when I get out of bed, I have to decide, do I want to live or do I want to die? She said, during those self-discussions, I have to convince myself that I can do it, because wanting to die is the easy way. Wanting to live is the difficult. So remember that with your clients. You don't deserve to live. A lot of times that self-hatred, personalized hopelessness, and then pushing away friends and family. What's wrong with you? Look at the trouble you're causing to the people who love you. If I just go away, everything will be better. And then you're seeing the extreme mood changes from A to Z. Isolation. Just go be by yourself. Move away from your friends and your family. You're better off alone. No one can help you. When they're in the good moods, they love to be around people. When they're in the bad mood, they don't, especially if there's any kind of criticism or anything that is said to them that they perceive as criticism. Thoughts of not belonging, I hear this a lot, especially with the LGBTQ group and others. You don't fit in anywhere. I work with a lot of young people that are LGBTQ that have attempted. And this one young lady I was visiting with, she said, a member of my church said, you shouldn't come to this. You don't fit in. Can I tell you, as a culture, we do very well shaming. We're very good at shaming, unfortunately. Past attempts. If you've attempted suicide, you're 50% more likely to attempt than someone that hasn't again. I talked about sleep. It's one of the critical questions you should be asking your clients. How is your sleep pattern? Because if they're staying up all night eating chocolate and potato chips and ice cream, I only do that once a week, but if they're staying up all night and then sleeping throughout the day, that's a disruptive sleep pattern. And can I tell you, when you start to work with families, one of the things that, as a therapist, I would bring the parents in first and meet with them. And I would outline the goals of therapy and everything that I was hoping to accomplish. And then I would ask the parents the tough questions, and then some of the things that I would ask them to work on. And one of the top things that I would ask the mother, would you please regulate your child's sleep? It's one of the most important things that we could do. The second is eating habits, and the third is exercise. But if we could help parents understand the value of those three. Increased anxiety, agitation, you'll see it them they're sitting there just tapping their foot, just not being able to slow down. You're seeing it with the drinks out there that have 9,722 parts of caffeine, right? And 4% drink. Outburst of rage or low frustration tolerance, and then risk-taking behavior. We are seeing activities in extreme sports that we've never, ever have seen before. And the casualties that are coming out of that are frightening. Frightening. Remember, the frontal part of the brain doesn't fully develop till you're about age 24 to 26. I have friends in their 40s, and I think it's still not developed, right? I tell one of my friends, I think he's fallen on it enough times. And Brent, I am not talking about you. I want you to know. What's the other part of it? Increased use of alcohol and drug use. Remember Dr. Gray's study. Sudden mood changes for the better. Those are the ones that frighten me. All of a sudden they start going to church. They start putting their affairs in order. Any talk or indication of suicidal ideation, intent, planning, anything that way. So how do we treat the suicidal patient? How do we work with them? People who are suicidal make up a very diverse group. However, and when I say that, you may have 20 clients and 3 of them, or even maybe 1 of them, but there's a commonality that we continue to see. Young people and adults. They have trouble regulating and tolerating emotions. Regulating and tolerating emotions. 1 second they're a fast train, the next thing that they slow down. It's at A to B. So it has to become the aim of the therapist to help clients feel connected, once again, connection. And then the other piece that goes along with connection that's just as critical is to feel valued. And can I tell you, for a lot of young people who are not being accepted by their peers, that can be very, very difficult. Very, very difficult. By the time you're in middle school, it's more important to have a friend than it is to belong to a family. Now, you and I as mom and dads go, wait a minute, my family's more important. Not to survive in society, it's not. Remember, Maslow says, families provide food, clothing, shelter, and safety. Society provides everything else. Think about that for a second. Think about your friends as you were growing up. They were the ones that had the ability to say, that is the stupidest looking shirt I've ever seen. Or, I would never wear those pants in public. Or, your hair looks terrible. If your parents said that, you would just do it to just tick them off that much more. But what happens with peers is you start to learn how to regulate. You start to learn how to find where those boundaries are of appropriateness in society. So, connectedness and valued. Important for you to form an alliance with that individual so they feel like they have someone on their side. In public education, we train school counselors because by law, we have to call parents immediately if we ever have a child talk about wanting to hurt themselves or to hurt someone else. And I have a lot of counselors that go, oh, I don't want to do it because the child will say, please don't call my parents. I'm going to be in so much trouble. So in order to be able to build that relationship, I train counselors to do 2 or 3 things. The first thing, in order to empower the young person, I will ask, who would you like me to call, your mom or dad? Because I don't have a choice. I'll lose my license if I don't call your parents. So who would you prefer? Oh man, don't call my mom, she'll lose it. Okay, let's call your dad. The second thing is, would you like to be in my office while we make the call? No, I want to sit outside. Okay, the third thing is, would you like to be with me when I meet with them? No, I'd rather wait in the conference room. We can do that. It's those little things that you can find to empower that individual so they feel like they are not all alone. Difficult to do in situations. The second thing is to provide structure so that they feel it starts to come together, because right now they're all over the place. So look at ways to provide that structure. And then valuable to actively include any people in the client's life who are capable of being a piece of support. Who are family members that you feel comfortable going to? Do you have coworkers? If you needed to talk to someone right now, give me the names of 2 individuals that you would feel comfortable going to. That's going to help me create their safety plan. Because you may be the first contact with that suicidal individual, you also may be the only person that they have contact with. The initial session could be the most important thing to the aspect of treatment. Don't treat them. Once you find out that there is a trickle or a thought of suicide, your brain thought has to change automatically. This is not my normal client. There are things that I'm going to need to do with this individual that I would not do with my normal clients. Safety planning is one of the first. Team up with a client to formulate a personal set of warning signs. because they are different for everybody. 3 years ago, we started a partnership with Brigham Young University, Intermountain Healthcare, and Provo Canyon Hospital. I went from being a principal to the district office, student services, and then associate superintendent. As I went back and started looking at the system that we had, what we found are those kids that were killing themselves had been previously locked up or hospitalized, and we never knew about it as a school system. Think about it. We have those kids 5.5 hours a day, 180 days a year. Sometimes more time than what a family has in connection. But we had kids that were attempting, and their parents were finding out, putting them in the hospital and never telling us. And they would come in and sign an excuse for a week long. We were on vacation. We were gone. They were ill. They would never tell us that they had attempted. Why is that? Why would you think parents would never say anything? Yeah, embarrassment, shame. I don't want anybody else to know. I want to protect my child. Problem is, it set us up for failure. And those were the kids that we tended to lose. So we set up an agreement with Intermountain Healthcare. Any child, any school-age individual that came in for treatment. Now remember, they come into Utah Valley, but they actually spend the night at Provo Canyon because Utah Valley doesn't allow anyone under the age of 18 in their program. So we had an agreement that when the parents would bring their child into Utah Valley, the emergency room social worker would have the parents sign a release that would give them permission to share the information with us as a school system. And we're very blessed in Provo School District. We have a social worker in every school. We also have what's called a family liaison. The family liaison and the social worker would get that information. And the other thing that I love about Wasatch, Gregor, I love Wasatch, they've been our best friends for 30 years, is that Wasatch will not allow that young person out of the hospital until they have a therapist assigned to them. That's a powerful statement that we believe in therapy and we believe in treatment. So we would then meet with the therapist as a school system and ask, what's the best way for Sally to return to school? Is it half a day? Is it online? Is it her regular schedule? What are the warning signs we need to be aware of? So we would start building that safety plan so that Sally could also have a pass so that each of her teachers knew if there was a moment or a trigger, we gave her permission to walk out of her class and come down to the counseling center. Can I tell you the amazing success we've had with that? Amazing success. So, team up with the client to formulate a personal set. I always go back to sleep. I know people get tired of that. Sleep, so important. Feeling increased agitation coming on? Are they having that critical inner voice? You're a failure, you're stupid. So we want to start defining those for that individual because we want that individual to be able to recognize those so that the red flag goes up. Work with the client to make the home safe. I cannot tell you the number of times that we've lost individuals because there was a gun in the home. Doug has a great story about a nephew with a gun that actually reached out to you, right, Doug, just before he was going to take his life. And wasn't he a veteran? A veteran. But if he had not reached out to Doug, we don't know what could have happened. You still have the gun. Good for you. Work with clients to make their homes safe. And in many situations, I train the parents, the spouse, to talk to the husband who has the guns, to say, honey, can we agree? Because last time you went nuts, and it frightened me, and it frightened the rest of the family. Can you and I agree that if there's a problem, and we start to see it happening, that we'll get your brother to come over and get the guns, and he'll lock them in his trunk of his car? And then once we're through it, he'll bring the guns right back. So we're not taking the guns away, we're removing them during that agitation period so that you start to help them understand. It's not gun ownership. Highest rates of suicide in the United States are homes that have guns. Homes that have guns, highest rate of suicide. There is a direct correlation. So, owning a gun, does that mean you're mentally ill? No. But what is it? It's accessibility in that crisis moment. So, it's getting those guns out of the house to help them prepare. Collaborate with the clients to develop a complete safety plan, referring to it regularly. Well, remember, Johnny, last time we met, we talked about the safety plan, and these were the 3 things that we went through. Constantly refer to that. Right? Everybody doing okay? Dang, you're quiet. I'm used to kids throwing things at me and calling me names. In terms of treatment, it's very important to obtain a commitment to treatment from the client, from the get-go. Outline a clear treatment plan of what you're going to do and then what you're expecting them to do so that we can make it a life worth living. Specify the task of therapy. We're going to start out twice a week until we get this built. We're going to do once a week. You're going to have homework assignments. These are the 3 things that you're going to... I have clients take a calendar and have them, especially when it's critical, either the parents or the individual, and I have them on that calendar every day, write how many hours of sleep they've received, how many meals, and their exercise. And I count steps, so I want to know how many steps you got that day. And then when I meet with them, that's one of the first things I'll do. Sally, let's go through the calendar together, because I'm training them, and it takes time. It doesn't happen overnight. Pay full attention to that suicidal client and try to get into their mindset by understanding the present crisis from their perspective. I was in the emergency room, and this young man taught me such a great lesson. He's screaming at his mom, aunt, and the therapist. And he said, "You're not listening to what I'm feeling." I thought he said, "You're not listening to what I'm saying." But he said, "You're not listening to what I'm feeling." That's where those emotions, that's where their pain is coming from. So, how do we work with you to change for you to not feel suicidal? Some things are going to be impossible. You're not going to be able to fix everything. And that's that educational part. You know, Sally, I probably can't get you a job at $150,000 a year. That's what I make, and you're not going to make that much without 27 degrees, right? In therapy session, allow the client to express the strong negative feelings that are creating intense psychological pain. It may be their parent, it may be their religion, it may be having been abused. There are so many factors that go into it. It's the voice that I'm hearing. Help me understand what that voice sounds like. When do you hear that voice? I want you to close your eyes and picture the last time you heard that voice. Where was it and who was there? Start building on that to understand. Clients are less likely to act on self-destructive thoughts and feelings if they have the opportunity to share them. Help clients goes back to what Joy said, right? We're not only not teaching kids, we don't know as adults, but help them to learn coping skills. I raised my family on a farm out by the Provo airport. I have 4 children, 2 boys and 2 girls. My wife and the 2 girls, you could cut off their arm and they would say, "Yeah." You get out a needle and us 3 boys are headed for the hills. I mean, our pain tolerance is about -7. Scares the heck out of us. Through the years, my wife, once she gets over calling me a sissy and everything else, she's trained me how to learn how to cope with pain. When I go into it doesn't matter where I go anymore. When I go into the dentist just for a checkup, I say, "Can I get morphine?" And they go, "No, Greg, you can't get morphine." Right? When I went in for stitches not too long ago, the doc said, "Don't ask for it because you're not going to get it," right? Because I love morphine. So, drawing from what has made them light up. What's the positive? What's the worth living? What has sparked their interest? Well, I would like to make as much money as you do. Okay, let's talk about the path that you're going to need to follow to get to that. The people that matter and who matter to them. Who are the two most important people in your life? And then one of the things that I really like to focus on, because of the physical exercise, is what are the activities that they've enjoyed in the past. Help clients learn those coping strategies. Actually create coping cards, little 3x5 cards. And when I'm having them make them, I'll make a duplicate so that I always have one in case they lose it. But then I can use that, and I have them bring that with them when they come to therapy. Because I want them to understand the positive actions. It's a reminder. You know, these are the things, Sally, that we worked on that you found to be very, very helpful. The coping card may be used to combat the voice attacks. We're going to number these. You have 4. Number 3 is when you, and I've even taken them and what do you call it? Emboss them? Is that what you, plastic covers, whatever? Yeah, whatever it's called. But I'll say number 4, or even I'll color code them. The blue one, because it's your favorite color, that's how you deal with inner voices. And when you start to hear those inner voices, I want you to pull the blue card and then start going through it slowly to remind yourself. I love what Dr. Robarch said. It is not enough to love the suicidal patient. It's not enough to give them hope. It's not enough to change their external environment. You must deal with changing the self-destructive processes, these inner patterns that erode the self and mental well-being. And can I tell you, they're dealing with that every time, every part of their life. All right, I have a video, but I want to open it up for questions or comments. Okay, let's have prayer and we'll go home. Any thoughts on it? Please. Be nice now.
You mentioned you had a slide that said do no harm. Do you have any examples or cautions for us about harmful practices, things that you know of that are going on, things that maybe we used to think were helpful that are not so much anymore? Or
yeah, great question, my friend. So here are some of the things that I've learned through the years, and a lot of these are from talking with individuals who have attempted suicide. Number 1, don't give them unrealistic promises. That's the most important thing. Yeah, I'm going to help you get into college. Yeah, I'm going to help you get this or that. So no unrealistic promises that. Number 2, be very fair and honest with them. So when they ask the tough questions, let them know I'm going to give you tough answers. I'm not going to sugarcoat this. If we're going to get through this, you have to work at it. There is no magical pixie dust. Let's be honest with each other. There is no medication that makes depression go away. There isn't. There's medication that helps you to live with it. There's medication that helps you function, but medication doesn't, or depression doesn't go away. And then I think the third thing is being very cautious to not set them up for failure. Expecting them to do things that they may not be ready at that point. No, I want you to talk to your mom, because that's what's creating the problems. That's a process, that's a journey. And there are things that I think we have to be careful that doesn't trigger something for them, because we may not know the background. We may not have worked with them long enough yet to really understand what that suicidal challenge is for that individual. Please. Oh, wait for the mic.
Do you have any comments about, you said copycat suicides. In my area, we've had 2 boys die by suicide in the last 10 months within a 3 to 5 block radius. So what would you recommend as therapists to talk to the parents about?
Yeah, so one of the very first things that I always is talking about it. So when I get called in to deal with a copycat or a contagion, I always have a meeting with the mayor, Chamber of Commerce, superintendent, mental health agency, faith-based leaders, and we sit down and have a very heart-to-heart discussion that we've got to start talking about it. We train parents in QPR, how to question, how to persuade, how to refer. We train them on warning signs, risk factors, what to watch for, so that they have that skill set of what to do. We're afraid to talk about it. We're afraid that if we talk about it, we're going to give someone the idea. The other thing we do is we train parents on how to ask the tough question. Are you thinking about harming yourself? Are you thinking about suicide? One of the most important questions we can ask. And not to be afraid with your children, even at the dinner table. You guys, I'm so sorry that Danny took his life, and I know this is difficult for you. Would you let me know if there's anything that I can do to help? And I'm wondering if any of you are having a difficult time. And then I tell parents, because parents will say, oh, we're worried about our son. First thing I ask is, who's the closest to the child? And they'll go, what do you mean? I said, who's the closest to him right now? The mom will say, I am. Then I suggest you take Danny out. When you meet with him, don't do it when you're angry, but take him out for ice cream. Go for a walk, and then just have that difficult conversation. You know, Danny, we lost Billy to suicide, and I know he's your friend, and I'm so sorry. But I'm worried now that it's affected you, and I'm wondering if you've thought about suicide. It's been amazing the number of emails and phone conversations I've got from parents that have said, one mother sent me an email and she said, after your training, I got in the truck, I'm driving home with my son, and I turned to him and she said, I'm sobbing. And she said, I just have to ask. And she said, then he started to cry, and he had actually put a plan together to take his life. We've got to start asking the difficult questions. Okay, we're going to move. Yes, please.
I have teens at home that unfortunately have had friends take their life, and they struggle every year on the anniversary of that.
Yeah.
Do you suggest continuing to have like ceremony activities and honoring the person, or is it better to redirect their energy to positive things so they don't go into a slump?
So here's what I like to do. If I have a child who wants to recognize, and I'll use Danny's name, I will say to my son, you know, Danny's anniversary is coming up this Friday, and I know it's going to be tough on you. Here's what I'd be willing to do. I'm willing to skip work, hate my boss anyway, but I'm willing to skip work, and if you and some friends want to go to the gravesite and we can leave some flowers, you guys can do something special, you tell me, how can I help? You want to have a night over here, pizza party? I'll do the pizza. You guys can be together out in the backyard or whatever. I want to control it. I want to do as much as I can to try to control, so I'm not just sending them off, but I'm going to honor that. So I'm going to take the initiative to say, let's do something. It's amazing what that does to the child to think, it means something to my father too, or it means something to my principal, it means something to my counselor. So I try to head it off at the pass and not hide it. But what I don't want to do is glamorize it, and I don't want to romanticize it. That's what happens when you start having what do they call those, the candlelight vigils that get together. Too many times they go, woo, off to the right, and sometimes it's hard to bring those kids back. Kathy and I, we went to every funeral of a suicide, and we would sit in the back of the church, the chapel, wherever it was, and we would just be monitoring those young people and taking notes of the kids that scared us the most, the ones that would fall on the casket, the ones that were so angry and they weren't showing emotions. They were just as high a risk factor as the other ones. Yeah, please.
I just wanted to clarify really quick. When you said earlier about Utah Valley Hospital having the letting the schools know, as well as not letting kids go until they have a therapist or a therapy appointment set up, That's no longer in practice. I don't know if you're aware of that or not.
Yeah, COVID has thrown us a curve for everything, and
Yes.
so, yeah, I do.
I've been down there in crisis for about 3 years, and I've never heard of that.
Are you in the emergency room?
I am, and I actually just got on my group text.
Yeah.
And none of my coworkers
So,
are aware of that.
David Woods from BYU, Jeremy Cottle from Provo Canyon Hospital, and who was at Utah Valley, Kathy? Trying to think of her name. But Jeremy Cottle, in fact, we just got a report not too long ago that shows the 100 students that were hospitalized. We average about 100 students a year that go through you to Provo Canyon Hospital. Do you know Jeremy Cottle? Okay. No, because you're the gatekeeper. You know, they have to go through you to get to Provo Canyon. So we'll get you the name of the supervisor, the individual that we originally worked with. Yeah, great. All right, other questions? All right, I'm going to move on then. It's important to work with emotions. Dealing with the intense emotions underlying suicidal behavior. Clients who did not receive acknowledgement of such powerful and overwhelming feelings as despair and helplessness reported being unable to move beyond them. So you've got to recognize those in the young people, in the client. Developing autonomy and identity, understanding suicidal behaviors, developing self-awareness, and constructing personal identity. Clients identify the therapeutic process as discarding negative patterns while establishing new, more positive ones. Even though some suicides are planned and some are more impulsive, all suicides have elements of both. That is why it's vital that we as therapists act quickly and effectively within the space and time between planning and action. This is an opportunity to help a person who is in crisis. All right, I'm going to move into the last part, the state of burnout for everybody, right? So let me jump to this, and then I'm going to come back to this video. So everybody, put your heads down. Just pretend you're back in elementary. But I want everybody to put your heads down and close your eyes. I know this is going to be more difficult for some of you than others. All right, so here's the question, no peeking. Raise your hand if you have felt burned out and overwhelmed in the last year. Okay, put them down. Raise your hand if you have felt and experienced empathy fatigue. Okay, put them down. Raise your hand if you have felt or experienced compassion fatigue. Okay? And the last question is, raise your hand if you are just feeling worn out and need a break. Yeah, I'm going to raise my hand with that one. Okay, you can open your eyes. I want you to see these two therapists just before the holidays.
Excuse me. I know you didn't think anyone would catch you, but you just slammed your door into my car. The least you can do is say you're sorry, lady. You don't have to take that tone. Excuse me. It's not like I'm hurting your resale. I know you didn't think anyone would catch you, but you just slammed your door into my car. The least you can do is say you're sorry, lady. You don't have to take that tone. It's not like I'm hurting your resale value. I'm sorry. See? Like that.
rates for mental health providers across the United States. Self-reported burnout in psychiatrists, 78% compared to 16% 2019. Self-reported burnout in mental health practitioners, 90% compared to 21% 2019. Mental health workers were never trained to be the pillars of strength for a nation struggling through a global pandemic. Yet when COVID-19 shook society into a state of crisis, you behavioral health specialists answered the call of duty, and now you're paying the price. I love this next quote. It's from the Kitchen Table Wisdom. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. Isn't that a great statement? Empathy fatigue and compassion fatigue are forms of vicarious trauma experienced by those with direct or secondary exposure to the trauma and emotional distress of others. We have lost friends that have been involved in suicide prevention who took their life by suicide because of the toll that it was on them. Mental health care providers and professionals in the helping field with little time for breaks in between appointments are often unable to emotionally refuel and recuperate after client interactions. I came home one day, my wife works from home, and I came home from one day and she was in tears, and I said, "What?" She goes, "I didn't even have time to go to the bathroom today." I was literally on, and she said, "My lunch break, the VA called and said, I need you to work with this suicidal patient." We're doing that more, we've done that too much. Signs and symptoms of fatigue, changes in mood such as lack of motivation, anger, anxiety, difficulty thinking such as lack of concentration, forgetfulness, problems, once again, sleeping, physical changes, loss of appetite, headaches, negative effects on work and personal relationships. Mental health professionals, try to get my left side when you take the picture. Did you get it? Okay. Mental health professionals are seeing increased referrals and requests for more frequent consults. Having to turn down clients leaves providers feeling guilty for not being able to help people in desperate need of care. 3 reminders of how you and I can shift the tides towards a better life balance. Number 1, know and respect your limitations as a therapist. What am I good at? What do I like doing? The importance of self-care for mental health, and then find social support. Know and respect your limitations as a therapist. Refill your tank before refilling that of others. When the VA shut down, we have an old family cabin up at Bear Lake, and my wife and I went up and spent 3 months up there. And when we were coming back, she said, "I hope COVID comes back." And I went, "What?" And she said, "No, just because we get to get away from all of the challenges and the frustrations." Look at scheduling augmentation, restricting work hours, and adjusting work schedules to create space for personal priorities, obligations, ensure you have adequate time to tend to personal needs, and the ability to recharge. It's important to check in with yourself, just like you expect your clients. How am I feeling today? How am I doing? Paying attention to the initial signs of burnout can prompt mental health clinicians to take action and seek help before long-term issues take effect. Your work is valuable, but remember, so are you. You have to be healthy in order to help others. Preserving the distinction between what your role is and is not in the client-provider relationship creates safer and more ethical client-provided collaboration that is ultimately more effective for both parties for long-term. Making time for personal restoration through activities that not only meet basic needs, but bring joy and fulfillment can replenish energy stores and providers. So the 2 things that I do that restore for me, one is I like to go sledding with my grandkids, and the other thing is a hot bath reading a book. It's amazing what that can do to help get away from the challenges. Self-care is not a luxury, but is a clinical and ethical imperative in the mental health profession. How can we tell others to self-care when we're not self-caring ourselves? Find social support. Finding a support group or community of people who can relate to the circumstances gives providers an outlet to discuss shared obstacles and emotions, letting you know that you're not alone in these struggles. Commiserating with others in the same field of practice can be challenging at times, but it helps to reduce feelings of loneliness and isolation for many working in behavioral health care. Growing a network of friends, family members, and peers establishes a ready, available support network when stressors and challenges threaten to destabilize the mental state of providers. So I want you to watch this video, and I want you to commit yourself to be like this person who's amazing, and look what she does to make a difference in the lives of others.
Hey, Melissa, the whales need your help.
I love whales! Go, Melissa! Let's protect those whales!
Hey, Melissa, now the trees need you. The ice caps are in trouble. Hey, Melissa, now the rhinos need saving.
It's hard to be an eco-warrior, but it's easy to drive like one. Introducing the most fuel-efficient crossover, the Kia Niro.
You know, my dream is after a training like this to be able to say to educators, law enforcement, or mental health folks, Kia has a brand new car outside for you, each one of you. Don't you love that? Who's the famous lady? Oprah, right? Yeah, I wish I could do that. So what are your questions or comments? We have about 10 minutes. What questions do you have?
I'm just sitting here thinking, Greg, I've known you now for 30, 35 years.
Yeah, it's been a long time.
Yeah, and as I'm sitting here thinking about our numbers that have gone up and down and up and down or whatever, I can't help but think, where would our numbers be had you not joined this campaign, this crusade, and you formed your organization? So my comment is just a huge thank you to you and all your organization for all you've done.
Thanks, Dean. I
Thank you.
appreciate that. Thank you. Thank you. I appreciate that. Other questions? Anybody? Yes, please, in the back, right there.
So you mentioned multiple times the importance of adjusting sleep, exercise, nutrition. How are you doing that aside from tracking with these patients who have limited capacity already with depression and what they're struggling? You know, even if you set up a system and they're still struggling to adjust it.
So if I understand how do I do self-care? How do
you recommend people help their clients to adjust those areas of sleep, exercise, and nutrition since they're so important?
Yeah, you know, it's a good question. It's tough. The biggest needle to move is those very things that you're talking about, because that's become a lifelong reaction. I try to start out early in therapy with that discussion, and then trying to build in benchmarks so that it's a realistic change and that it's a realistic move, and not expecting everything to happen at once. Too many times I think we expect change, more change than what's, you know, depending on the individual you're working with, you know, these are lifelong things that they have been challenged with in some situations, and lifelong responses. So you have to figure out, how do you make, what's the one show, Baby Steps? What's the one show, what about Bob? I love that show. And I've even had clients watch it, and then we talk about it. But, trying to make those small gains and not. Dr. Gray one time made a comment to me, and he said, I've been working with this individual for 9 years. I went, what? He goes, 9 years. And I said, how's the progress? He goes, I'll need about another 9, but we're making progress, right? So those are the tough things. Please. There's a mic right behind you.
How do you help clients when parents or ethics or organizations are in the way? What resources are available to say, I know a child who's at risk, but I don't have access, or I don't know how to help them?
Yeah, confidentiality makes it difficult in some situations, but FERPA makes it difficult in public education. So I can meet with the parents, but it doesn't go much beyond that, except staff. But what I like to do is I will get permission. I try to gain permission from that individual and the adult. Would it help if I call the school counselor? Would it help if I reach out? I have some colleagues at Wasatch Mental Health or, whatever that way. One of the things we learned early on in youth suicides is that it does no good to identify kids that are in crisis if there isn't a resource for them afterwards. And I don't care who you are and what your level of skill set is. When it's your child who's suicidal, forget everything you know. Forget everything you know. I've met with doctors, therapists, professors, professional athletes, you name it, and their child was suicidal. Forget. All they're hanging on is that my child will live. Tell me what I need to do. And so you then have to become that professional to help them learn what the resources are and things that are available. On our website, hopeforutah.com, hopesquad.com, you can click on resources, and we list every provider in Utah County. We list how much they charge, what they specialize in. So we now meet with parents and say, what's your insurance? And then we start from there. Well, this agency takes your insurance, this doesn't, and so that we can at least provide that. Well, we were talking earlier, it just made me think of it. Top 2 places kids are cutting themselves, top 2 places. Between the toes, under the armpit. Why is that? Yeah, because we've trained parents what to look for. 88% female, 12% male cutters. There's now sites on the dark web that kids are going to, signing up, and they're actually showing them cut themselves and sharing it with their new group of friends. For the first time ever, about a year and a half ago, an individual from the CDC made a comment we were at a conference, but he said, we're now seeing a direct correlation from cutting to suicide, where before it was cutting, depression, and then suicide. So if you have a child, and can I tell you, we're seeing more and more cutting in elementary age. We're seeing anxiety, depression, and cutting, 4th, 5th, 6th graders. Other questions? Please.
So if you have a client that's somewhat high risk and you're going over a safety plan with them, and they're kind of just like half-assing it, and they can't connect anything that makes them light up anymore, and it's like they don't have, like at what point do you make the call if they don't have an active plan but they're also not able to actually engage in a safety plan?
Yeah, that's a good question. And I'm not sure I know the exact answer to that, except I try to do as many safety plans, and it's been amazing the number of times I've had that gut instinct to say, I'm worried about this client, So then I bring up the safety plan. And later on, they will say, how did you know I was suicidal? And I will say, I was guessing, to be quite honest. I have had clients push back and say, I'm not doing that. And there are times that I have had to say, there are certain conditions for me in order for me to work with you, and that's one of them. So if I don't see any progress with that, I'm probably going to refer you to someone else.
Oh, sorry, okay. Question, how do you deal with compassion fatigue for clients that are maybe borderline? That will research certain things to make sure that they won't kill them, but then do it to try to get that attention?
Yeah. I used to run a group, and I'll never forget the one time, and they were all court-ordered kids from Kay Lindsay, Gregor, and Brent. But I'll never forget, it was Friday afternoon, whatever, and no, it was actually Saturday, but at the end of the session, the girl walking out, borderline, and she said, oh, by the way, I'm blankety blank, thinking about whatever. And so, of course, I had to run out in the parking lot and talk to her, and it was like, well, why didn't you share with me, why didn't you share with the other peers when that was brought up by one of the other members of the group? And she made a great comment. She said, I just knew how to push your button. And I said, bingo, right? You have those. And, the challenge for us is you have to take everyone seriously. So I treat it that way, and I tell them that. I share the story when I work with my educational colleagues. We were, for Christmas, we had all of our family. There's 5 families that have this cabin together, and I was up on the very top, and there's, like 25 people or whatever. And my granddaughter, who's 16, or at the time she was only 12, she turned to her brother and she just blew up and said, well, I'm just going to, kill myself, whatever. I don't know what it was. And I thought everybody was going to look at her. Everybody looked at me. And I'm going, wait a minute, she's the one that said it, right? So then I went and met with her, and she said, I knew you were going to come and meet with me. And I said, why is that? She said, because I mentioned the S word. And I said, it's one of those things that I take serious. Doesn't matter who I'm with or what I'm doing. When that comes up, I'm going to treat it like that. But I will say, over a period of time, if I'm not seeing progress, then those are part of those difficult discussions with the client. This is what I'm willing to do for you. These are the things that you've got to be willing to do for you, right? Otherwise, it's the fatigue burnout. They just keep chipping away at that armor, and pretty soon there's no armor left for you. Any others?
Greg, we have a question from our virtual attendees.
Yeah, please.
How would you recommend proceeding if a parent is just not taking their teen and the suicide crisis seriously?
Now say that again. Say it kind of echo.
So how would you recommend proceeding if a parent is not taking their teen and their suicide risk seriously?
Yeah, that's a difficult one, and we have that in the school system constantly. We unfortunately had a girl who had written a note that she was going to take her life. We brought the father in. We said she needs to go to Wasatch. They were going to do an assessment for us. And the dad said, no, you're not. It's my daughter. I make the decision. And we said, we know, but we're very concerned about her. She had made comments. And the father grabbed her daughter and said, we're leaving. This is none of your business. And that very night, she attempted suicide and ended up in the hospital. I don't know. I try to play off of the concept of, we need you to be aware that we've had some suicides that we're very worried about, and this is a real thing for us. And then I talk a little bit about the statistics and the numbers that we have faced as a community. And, I'm pleading with you to at least have them evaluated, to at least maybe meet with a mental health expert. And then that way you don't have to, you're going to at least get some good feedback on whether or not your child is at risk. Because right now, you and I don't know. But we're worried enough about it that I think she needs help. That's a tough one. Changing the parents in today's society is very difficult. Other questions? Okay, I'm going to end. I have one last video since I'm the video king today. And I want to end on this one just because every one of us have an opportunity. And can I just thank you for what you do and the amazing differences that you're making. Take time for yourself. You're not going to be able to help that client unless you help yourself. So let's see how this one works.
เขาจะได้อะไรถ้าเขาทำแบบนี้ทุกวันเขาจะไม่ได้อะไรเลยไม่ได้รวยขึ้นไม่ได้ออกทีวีไม่มีใครรู้จักไม่ได้มีชื่อเสียงที่มากขึ้นเพราะสิ่งที่เขาได้คือได้แค่ความรู้สึกได้เห็นความสุขได้เข้าใจได้ความรักได้ในสิ่งที่เงินซื้อไม่ได้ได้โลกที่สวยงามกว่าเดิมในชีวิตคุณอะไรคือสิ่งที่คุณต้องการมากที่สุด
ไทยประกันชีวิตเชื่อในความดี
So let other people help you. Thank you for coming. Nice to be with you.
Thank you, Dr. Hudnall. And thanks to all of you for being here, and more importantly, the work you're doing in our community to help solve this very important thing we're talking about today. You should be getting a feedback form brought to your table. Just fill it out at your table. And then when you are done with it, you can pass by the table in the back and you'll get your certificate. Those of you online will get that through email. While you're completing this, I'll just talk a little bit about Scenic View Academy. My name's Alex. I'm the admissions director at Scenic View. We host this training as well as a training in the fall. Expect some more information coming about that soon. But what we do on a day-to-day is we work with adults on the spectrum. And we teach independent living skills here on campus. This is our community building. We've been around for about 20 years, and we've helped a lot of people achieve independent living. One of the things that I know Greg would know a lot more about this, but with neurodiversity comes an increased risk of suicidality. And so, our clinicians are trained to work with neurodiverse adults, but we also have an outpatient portion to our program where students or clients from the community, children, adults, families can come receive therapy here at Scenic View specific to autism. We do testing, we do that as well. So just wanted to make you aware of that. If you want more information, you can always find that out. And thank you for being here. Again, get your CEUs from Amber in the back. As soon as you're done, you can head on out the door, and we'll see you next time.
Transition to that thing. Hello, hello, hello. 1, 2, hello, hello, hello. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Okay. So that like it sees it, but it's not sending it. Is that right? One, two, three, four. Why can't I hear you? Hello, 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 hello. One, 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 one. So the question is, why can't I hear you? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Why can't I hear you?